Welcome to the upper airway. So we're going to talk a lot about just the straight anatomy and a little bit of physiology of the upper airway. This is going to come in very handy for all respiratory therapists, whether you work outpatient and go house to house for people that have chronic breathing problems, or if you work in subacute, or you work in acute care, or you work in diagnostics. All of these areas, you will need a good foundation of the airway anatomy, both upper airway and lower airway. And so this is going to be sort of an area where I'll stress some important parts or some application points of where you might need to recall some of this information in both acute care and subacute care and all different areas of respiratory care. This is going to be a pretty universal need or function that you're going to have down. So let's get started. And on this first slide, I just want to reiterate that some of the best ways to be successful in this course is read the chapter ahead of time. So if you read ahead of time, yes, a lot of it may go over your head, but these are just some things some students that have been very successful have said have helped them. Read the chapter ahead of time, then do the lecture, and then sort of fill in the blanks there, sort of see it as I lecture, some of that stuff will come to make sense that you've already tried to read through the chapter. So even though it may be a foreign language the first time you read through that chapter, please go through it, go through those sections and just read it ahead of time. Like I said, don't get frustrated with it, but just go through, get yourself sort of familiar with some of the stuff that we'll cover, then come to the lecture. And then once we're in the lecture, we go through the lecture, then I would go through the workbook to sort of see what areas you have down and what areas you don't. That workbook is going to be helpful to you as a tool to see what areas you need to grow on, what areas you've got down. And don't be surprised if you don't see workbook things in the future on assessment documents. So some of those big success things, make sure you look at the recordings. Some students say that rewriting the notes by hand have helped them out as well. And especially if you bullet point the rewriting of the notes, that's going to be very, very useful. Read all the clinical connections in the chapter. So in the chapters, it talks about different things where you might see this information down the road. And the cool thing, if you're a visual person, when you read those clinical connections, it sort of gives you a mentality of, okay, put your mind, you're in a patient's room and this is going on, this is the application to this information. So it might be more kinetic for you to do that imagine thing with that clinical connection, and it gets the material deeper into your mindset, so down the road you'll actually be able to recall it a lot better. So read those clinical connections, do the workbook, make flashcards or Quizlets, color in the workbook, do all those things that make you sort of have that connection to the material, whatever it takes. And Desjardins can be different. In some people like the way it reads, some people it doesn't connect with how they would read information. And so I'll try to break it down a little bit for you and stress some important areas, but be aware, I will ask questions of you that are from the workbook or from the chapter that we may not cover in the lectures. I'll say that again, be aware. I may ask questions of you that were not covered in the lectures, but were covered in the book and in the workbook, right? So make sure you're going through that material. I am only an addendum. I'm only highlighting the material to get some of the main points across. There's not nearly enough time to go over every little detail that needs to be gone over, but hopefully this will sort of help you out. So let's get started with the upper airway. So when we're looking at the upper airway, we're looking at the respiratory system. This is the introduction, right? This is where gas will first start to go into the respiratory system. All the cells in the body require an abundant and continuous supply of oxygen, right? So that's one of the big key things, is when a person becomes what's called hypoxic or hypoxemic, emic meaning in the blood, right? If there's a low oxygen level into the body or in the blood, the things like the heart, the kidneys, the brain, the liver, all these organ systems start to shut down, right? You need oxygen to sort of fuel and keep your body's life systems functioning, right? And that's one of the key things that you'll look for in critical care medicine. Someone's super sick on a ventilator, and one of the big things when their kidneys are starting to shut down, when everything's starting to shut down, is the fact that most likely they're hypoxemic, right? They most likely don't have enough oxygen going through their body, because the body needs a continuous and abundant supply of oxygen. Without oxygen, your bodies will shut down, and it's going to be one of those bad things. So remember, oxygen will go into the lungs. The lungs, they'll go into the primary parts of the lungs, and they'll go to these little sacs at the end of the lungs called alveoli. And from the alveoli, they'll go into the bloodstream. From the bloodstream, hopefully they'll get transmitted to the cells, where the cells use and make CO2. That's the byproduct of this. And when that happens, we're going to get that CO2 into the blood because we need to get rid of it. That's carbonic acid now. And then that's going to be hopefully sent back to the right side of the heart, where it goes into the lungs, and then goes to the alveoli, and then it gets rid of CO2, and then your lungs, right, when you exhale, will get rid of that CO2. So it all starts with that inhale with oxygen and exhale with that CO2. So all cells in our body require an abundant and continuous supply of oxygen. As the cells use oxygen, they release a waste product called CO2, or carbon dioxide. Right, and so that's going to be one of the big things. So far, your respiratory system, and we haven't gotten to the third point or fourth point yet, but so far your respiratory system not only is in charge of getting oxygen into your body, but the respiratory system is in charge of getting CO2 out of your body. That elimination of carbonic acid is also a very valuable point. Okay, so in your red blood cells, and you guys may have gone over this already in A&P, you have something called hemoglobin. Hemoglobin can attach for every hemoglobin, it can attach 4 oxygen molecules to it. And so what happens is, if we get the ability, and let's say this is oxygen that's attaching to these hemoglobin molecules here, right? This is great. This is a perfect relationship. But now we get to a point where someone stopped breathing. So let's get into a scenario where someone may have taken too much pain control medicine, and they're breathing very shallow. They're hypoventilating, right? And so instead of oxygen being on those hemoglobin molecules, what will happen is, because they're not breathing, CO2, and let's just use a different color here, CO2, let's just use green, is now attaching itself to the hemoglobin molecule, and then when it goes to the lungs aren't getting rid of the CO2. There's no CO2 diffusing into the lungs. And so how much parking space, how much room is there for oxygen to then get on that hemoglobin molecule? Not much room at all, right? The parking spaces are mostly taken up by these CO2 molecules that are just hanging out, right? So if you're not exhaling, if you're not ventilating, if you're not breathing, your ability to get oxygen into your body and into your cells is significantly reduced. So I will say, not only is it important that someone breathes in, but it's also important someone breathes out as well, right? We need to get rid of this carbonic acid, and if we don't get rid of that carbonic acid, then our ability to get oxygen to our bloodstream severely diminishes. So this is sort of the case, and you'll be asked this on the national board exams, is they'll give you a situation where someone has very low oxygen level and their breathing rate is really low too. I'll do RR for respiratory rate. So both of these are low. So your oxygen levels are low, and they're what we call hypoventilating. They're not breathing very deep at all, or breathing very much at all to begin with. So the question that they're going to ask you ultimately comes down to, what do you do first? Do you give them oxygen, or do you improve their breathing? Well, which one would you do first? Well, based upon what I just told you up here, you'd want to increase their ventilation first, because if we increase their ventilation, we get rid of these carbonic acids that are just hanging out on the hemoglobin molecule. If we get rid of them, those parking spaces become vacant, and therefore there's more room for oxygen to jump onto that hemoglobin molecule. So that's what they want you to look at. They're like, what's more important with a patient that's not breathing and has low oxygen levels? The not breathing part or getting oxygen to the bloodstream? I can tell you now, if they're not breathing, I can give them as much oxygen in the entire planet as I want to, and it's not going to make a difference because they're not getting rid of CO2. They're not getting rid of that carbonic acid. So I hope that I've made that stressful point to you, that CO2 and exhaling is just as important as oxygen from inhaling, right? It's important that you eliminate your carbonic acid out of your system. And we'll get into further detail down the road in this class on that as well. And even in disease class, when we talk about conditions that make it hard for people to breathe out, like obstructive lung disease or COPD, it makes it hard for people to breathe out because there's something that's stopping gas from getting out, which means their CO2 levels go up and therefore their oxygen levels go down, right? And so both of these need to be functioning well in order for someone to maintain their good old homeostasis, right? So finally, to the third point, these oxygen-dependent cellular processes. So once the oxygen gets to the tissues, the muscles, the cells, the organs, let's say kidneys, right? Once they get there, these oxygen-dependent cellular process, it's asking about cellular respiration. I'll repeat that. Cellular respiration. So, or the other term for this is called cellular metabolism. Once again, cellular metabolism. So that's what should be in those two blanks there, cellular respiration or cellular metabolism. So this is your body's metabolic rate. And what's really neat, there's actually a documentary on, I think it's Disney Plus, about running a marathon in under 2 hours. And they actually talk about this. So if you have a chance to go watch that, they actually talk about this. I think it's called Under 2 or something like that. And they actually talk about the metabolic process of these athletes that are trying to run all this distance where their body's creating CO2, their body's creating that metabolic acid and that carbonic metabolic acid, and they're trying to find a way to make it where their body's more efficient at using oxygen. So it has a lot of applications here, and metabolism's a very important thing. Let's say we have a patient that has a very, very high fever. Let's say we have a patient that has a sepsis, a blood infection, and that infection's causing a very, very high fever on that patient. Well, what happens to your metabolic rate if you have a high fever? Does it speed up or does it slow down? Right? It speeds up. And because we have a faster metabolic rate, our body's consuming more and more oxygen and producing more and more CO2. And so that's what we're looking at here, is our dependent cellular process is the metabolism. So therefore, if we have a patient that has a high metabolic rate from an infection because of a fever, then we know that the amount of oxygen that we're giving them is probably going to be high, and the requirements for them are going to be high. You're like, why is this important for me, Derek? Well, when we have this patient on a lot of oxygen, and all of a sudden we start to see their saturation start to go up, then we know that their body's not requiring near as much oxygen. We see their oxygen levels in their body start to improve without us making any changes on our machines, right? Without increasing any oxygen or anything like that. We start to see their oxygen levels in their bloodstream improve. then we know that their body's getting better. Their metabolic rate is slowing down. Their fever could be going down, right? These are all good signs this patient could be getting better. But do you want to overdose a drug? And oxygen's considered a drug, right? If it's anything above 0.21 in the FiO2 world, no, right? There's a lot of bad things to that, and we'll get to that as well. So this comes in very, very handy, right? We want to make sure we're giving the patient the right amount of oxygen for their metabolic rate, and not too much, right? When we give it too much, there are other bad things that happen. So number 3 there, oxygen-dependent cellular processes are called cellular respiration or cellular metabolism. And number 4 here, the major role of the respiratory system is to supply the body with oxygen, right? This is where we start off. Dispose of carbon dioxide, get rid of that carbonic acid, get rid of that metabolic waste, right? And then finally, allow for cellular metabolism to continue without interruption. Because what happens if we stop giving the body oxygen, right? Well, what happens if something obstructs their lungs, right? They're going to produce even more CO2 because their body runs out of oxygen. They're going to go into what's called anaerobic metabolism, and that causes a lactic acid buildup, which then will cause the CO2 to increase, which then causes the organ systems to shut down, and the ability to get oxygen onto that hemoglobin molecule diminishes. So there's a lot in here, and hopefully you guys can slow this down, rewatch it, right? So just take it step by step here. A lot of information, but it's very, very important. The respiratory system, when we're looking at functions here, so I might ask you in a future assessment document about functions. So this is sort of the overall big picture. What are some of the big main things that the respiratory system is supposed to do? And we did talk about oxygen and CO2 and metabolic rate. But when we're looking at the overall big picture of things, there are 4 distinct processes, right? We need to supply the body with oxygen and remove CO2, but how does it do it? What's the process of this exchange of gas? What's the process of exchanging oxygen for carbon dioxide? And there are actually 4 distinct processes. Number 1 is called ventilation. So that's what should be in that blank there. Ventilation, right? Right, my handwriting's not good, but there you go. Ventilation. This is definition, right? I'm very, very strong on asking you definitions of things. So that might be something you would want to highlight. The definition, this is the movement of air into and out of the lungs. So we tend to think of this as your breathing, just your normal breathing, the movement of gas into and out of your lungs. This is ventilation. Why is the VT there? Why is that there? Well, that stands for tidal volume, and you'll see that a lot in science class, and hopefully that sort of breaks the ice for you. You'll see it a lot in this class as well, where it's talking about VT is volume tidal. So tidal volume literally comes from looking at the tidalling of waves of an ocean, right? So you see those sort of tidalling of the waves, the peaks of those waves, and that's sort of that breathing. So this is thinking breathing in, breathing out. Breathing in, breathing out, breathing in, breathing out. It's that tidalling. It's that exchange of gas is what we're looking at. And so that's what people look at. When they look at the lungs, if you look at a patient that's laying down, you'll see their chest rise and fall, rise and fall. And that's just like a tidalling of a wave, right? That rise and fall represents how much volume of gas they're moving, and that's called their tidal volume, right? How much volume is that patient moving? That's their tidal volume. And so it looks like that tidalling of an ocean if you're looking at their chest wall, right? That's what you want to see. You want to make sure that they're breathing. So 2, the gas exchange between the blood and air-filled chambers of the lungs is defined as external. External respiration. So I don't have enough room to write it in. External respiration is defined, notice the definition, I will ask you that in the future, of gas exchange between the blood and the alveoli, right? And so this is where, hey, I've taken a breath in, And that went all the way from my mouth to now, remember that little, they show little pictures of alveoli, and then you have a capillary running along there where it gets into the bloodstream. So this is that gas exchange between the alveoli and the capillary that's surrounding the alveoli, that little blood vessel that's surrounding the alveoli. This is where the gas exchange happens, and one of the ways I like to remember this is that we have external gas being changed over internally, therefore it is external respiration, because we have external gas going in. External respiration is external gas going in, which would be at the alveolar capillary membrane. And this will make sense because when we get to number 4, that's where we talk about internal respiration. So internal respiration here, internal respiration is the gas exchange between the blood and the tissue. So when we get to the blood and the tissue down here, hopefully you can all see this, when we get to the blood and the tissue, this is that metabolic rate, right? This is that also known as your cellular metabolism, right? This is what you're looking at there. So this would be internal respiration, where it's from your blood to your muscle, right? I'm just using muscle as an example here. That would be internal respiration. That would be cellular metabolism. External respiration would be between external gas and the body, right? Which would be in your alveoli and your capillary. So there's a difference between the two. I do expect you to know the difference. One of the very last lectures of this course, we will be talking about more in detail about the difference between external respiration and internal respiration. So this is going to come in very, very handy, especially for the final exam. So number 3, I know we're sort of skipping there, is the transport of gases. So once we ventilate, right, so if we're looking at number 1, we get gas going into the lungs, then it goes into external respiration where it gets into the bloodstream. All right, that's great. We got oxygen all the way down into the bloodstream. Okay, that's good, but it doesn't mean anything if our heart's not going to pump it around to our tissues, to our muscles, to our organs, right? So in order for us to get gas, right, good, strong oxygen to our body, to our systems, so we don't go into anaerobic metabolism, we have to have a good heart function. We have to have good blood and good heart, right? And so we're going to go over this in more detail as well, but we need that cardiovascular system to deliver that oxygen. And if it's not delivering the oxygen, if someone's in heart failure where that pump is not squeezing very effectively, then our ability to get oxygen to our kidneys, to our muscles, is going to be significantly reduced. Our ability to get it to our brain and our liver and so on and so forth is going to be significantly reduced. And one of the key points of respiratory therapy overall is not only pulmonary function of our patients, but also cardiac function of our patients. Because if their blood pressure is low or their hemoglobin is dysfunctional, right, their ability to get oxygen to the tissues is not going to be strong. So we need to know the cardiac physiology. We need to know what's going on with the heart, because that heart is the important part of delivering the oxygen to the cells, right? Think mentally. You order something online. That's great. But does it mean anything to you until it gets delivered to you, right? You can't use it until it's delivered to your house, right? And so that's what we have going on here. That delivery is done by the heart, that cardiovascular system. We need good, strong blood vessels, we need good, healthy blood, and we need a good heart, right? And so those are going to be important. You're going to see a lot about that. I'll stress it in this class, and you'll probably stress it a lot in cardiac A&P too. But that transport of gas is very important. Like I said, order something online. It's that transport of that thing to you that's going to make it useful to you once it gets to you. But you can't use it until it gets to you, right? Same thing here. Your heart plays a very, very important role, right? So when we're looking at this, that's when it gets to your cells. Then we'll have that internal respiration where we actually supply that muscle with oxygen. And then obviously oxygen has now jumped off of the hemoglobin molecule, right? So that's kind of cool. So we have our hemoglobin molecule that's traveling towards the tissue, right? And then we had oxygen that jumped off at the tissue. So now this hemoglobin molecule is all lonely at the tissue. And it's like, well, I got to go back to the lungs. Do you want me to take anything with me? And they're like, sure, I got carbon dioxide that can park on your hemoglobin spaces, right? And so then the hemoglobin molecule is going to pick up that CO2 and then travel it back to the lungs. Pretty cool, right? So it's a very efficient system as long as it's working, right? And this is where we come into play. What happens when the system isn't working? What happens when someone's CO2 level is super high and their oxygen delivery is super low? What happens if someone's blood pressure is super low and they're vasodilated, right? What happens if their blood vessels are dilated like in a severe sepsis, right? Their ability to deliver oxygen is going to be very, very poor. And it's going to be very hard for them to maintain life function, right? What happens if their heart, the left side of the heart, is in failure from years and years and years of chronic hypertension, right? Their blood pressure was so high for so long, it caused a lot of damage to that left heart, and that left ventricle is just not pumping as much as it could anymore. And their delivery of oxygen can be very, very poor. Right? So it's important that you know these things. And then we can get into, hey, how do we help a patient that has a heart that's failing? Or how do we help a patient whose blood vessels are dilated? How do we help these patients so they can get the right amount of oxygen to their brain and to the heart and so on and so forth? So hopefully I've sold you on the importance of all of this. Alright, so this is looking at the straight anatomy. The straight anatomy here. The big point I want to look at here, and you'll have this in your book and go over this. I will not make you label anything in the exams. It's just very hard to do that in this manner. But I want you to look at this one specifically at the separation between the upper respiratory system and the lower respiratory system, and we'll call it the vocal cords. So here it's saying anything above the vocal cords is considered the upper respiratory system. Anything below the vocal cords is considered the lower respiratory system. And so today we're just going to talk primarily about the upper respiratory system. Well, this whole area up here. And so why do I make the vocal cords there? Well, A, that's in your text, but B, when we're doing things like a bronchoscopy where we take a camera and we put it usually through the mouth nowadays, but we used to put it through the nose, and we go into the lungs to go look around or collect samples or to obtain things like mucus or foreign objects, right? We're going to go through the upper respiratory system, get into the lower respiratory system. You're like, okay, that still doesn't tell me why I need to know this. Well, there's a lot of application to this, so we'll get into it as we go along. But above the vocal cords, we actually give a topical anesthetic called lidocaine. And lidocaine we give in higher concentrations, usually in the upper airway. Usually we'll do a 4% or a 2% concentration. You don't need to know that. I'm just trying to give you an application point here, because there's less absorption into the bloodstream with the mouth and the throat before we get into the lower respiratory tract. And so our dividing point is usually the vocal cords. Once we're past the vocal cords, as far as respiratory therapy procedures go, we're considered in the lower airway, and therefore we actually change the dosage of what we're doing. We change what we're doing because we've now reached the lower respiratory system and we're no longer in the upper respiratory system. So your key point to take away here, if that application point didn't hit home with you at all, is that the separation between the upper respiratory and the lower respiratory system is the vocal cords. So functional anatomy, so let's just start with the very beginning here. Respiratory organs include the nose, the nasal cavity, so you have the nose at the very front, then you go into the nasal cavity itself, then you go into the different pharynx, so you got the nasal pharynx, then you go into your larynx, so that'd be your oral pharynx. your trachea, which would be right below your laryngeal pharynx, your bronchi, so this is going back into the lower respiratory system here, right? So once we go into the trachea, which is where the vocal cords are located, here, let me use yellow. Once we get here, once we get to the larynx, that's where the vocal cords are. So that's when we go into the trachea, bronchi, bronchioles. So this is the tubes just getting smaller, and then finally we go into the alveoli itself. So that's just that functional anatomy of that breathing in. So when we're looking at the different airways of the body, we're looking at dividing it into two general zones. And they have different purposes, and that's why it's important we separate them. We don't separate them because it makes it sound smarter. It separates them because they have different functions, right? We have the function of the respiratory and conducting zones. That's what should be in here. The respiratory and conducting zones, right? The respiratory and the conducting zones, they both do their own thing. They both have separate purposes. They both have separate things to do with each other. And so that's why we're going to go into that differentiation here. The conducting zones' job is to transport, clean, warm, and humidify. I know you can't read those, but my pen is not great. But the conducting zone's job is to transport, clean, warm, and humidify the incoming gas, right? So that's the whole point. It moves it from the outside of the body, it filters it, it heats it up, and it gives it humidity. So that way your cellular processes within the respiratory zone are good to go. It's a way we want to make sure that that air is clean and filtered and ready to function for gas exchange for our bloodstream. Can you imagine if we didn't warm up the air before it got to your bloodstream? What would happen to your core temperature? What would happen to your body temperature if we didn't warm it up, right? It would be very, very cold. What would happen to your body if it didn't filter, right? If it didn't clean it? Then you would have a higher chance of infection, right? Even blood infection, right? What would happen if some of the nose is blocked, like a choanal atresia, right? Let's say part of your nose is blocked, or part of your throat is blocked off. Well, you can't transport the gas in there and therefore exchange gas with the blood down the road. So all these filters are important, right? So this is one of the big things here is the conducting zone is warm, transport, clean, warm, and humidify. These are all important functions up here. And the conducting zone is everything up here. We talked about the nose, nasal cavity, larynx, and the pharynx, right? So we'll get all the way up here, right? And then we're looking at a different function than the respiratory zone. And when we get to the respiratory zone, this is gas exchanged with the blood. This is what occurs in the respiratory zone. It does not occur in the conducting zone, N-O-T. It does not occur in the conducting zone. Once again, exchange of gas between the bloodstream and the lungs doesn't happen in your nose. It doesn't happen in your trachea. It doesn't happen in your bronchi. It happens in your alveoli. It happens in your respiratory zones. So we have different functions. One of them is to transport, clean, warm, and humidify. The other one's purpose is to actually exchange the CO2 and the O2. Right? They have different purposes. That's why they're going to have different anatomies, right? You're going to have the conducting zone that has pseudostratified, ciliated columnar for the most part to filter, heat, humidify, so on and so forth. And then when you get to the respiratory zone, it's going to be simple squamous, right? It's going to be very, very thin because it's got to exchange and diffuse gas. So it's going to be a very thin membrane. So functionally, they do different things. That's why we're drawing this distinction between the conducting zones in the respiratory zones, right? One of the things that you will hear, and this is a term that you'll see in mechanical ventilation as well, when you get there, and like I said, I don't want you to think about this right now, is that the conducting zone is also known as dead space. Well, what's dead space, right? When we're looking at dead space is blood flow without exchanging gas. So in your alveoli, so here we'll draw an alveoli, we'll draw blood flow, right? There's gas being exchanged here. We're getting oxygen into the bloodstream and CO2 out of the bloodstream. Now over here, so that's functional. Over here, let's say we have a, a trachea, right? We have a trachea, and is there blood flow to the tissue of the trachea? Well, I hope there is. That's how all pretty much organs stay alive, is they have some level of blood flow to them. So there's blood flow going to the trachea, but is the trachea exchanging CO2 and O2 in that blood flow, in that air that's coming in contact with it? No, right? It's just supplying it with blood to nourish that tissue. So it's called dead space if there's perfusion without ventilation. If there's blood flow is what's known as perfusion. So if there's perfusion without ventilation, if there's no gas exchange. So if we have blood flow without the exchange of gas, then that's called dead space. You're like, why is this important, Derek? Well, there's a lot of important reasons to this. Is when we intubate someone, when we put an artificial airway in, whether it's a tracheostomy tube or an endotracheal tube, right, where we put that tube into their lungs, we actually decrease the amount of dead space the patient has because we're bypassing their oropharynx, their nasopharynx. We're bypassing a lot of these processes, and so therefore we'll be more effective at helping that patient exchange gas when we put in those artificial tubes. When we put in the endotracheal tube, when we put in the tracheostomy tube, we're actually going to help that patient ventilate more effectively, right? And that's one of the indications for mechanical ventilation. If their CO2 level is too high, or if their pH is too low, or if their PaO2, or how much oxygen is in their bloodstream, is too low, then we'll put them on a ventilator with an artificial airway, whether it's an endotracheal tube, endo means within the trachea, right, endotracheal, or the tracheostomy tube that goes between the second and third tracheal rings. We'll do that because it reduces dead space and it makes exchanging gas more effective, right? It makes it easier to exchange gas because we're getting rid of that whole perfusion without ventilation. We're getting rid of some of that surface area because we're bypassing it, right? We're bypassing the whole upper airway with an artificial tube. That's not going to take near as long or anything. But here's the warning that I have for you, right? And this is something that will be universal. On the upper airway, if you bypass it with an endotracheal tube or tracheostomy tube, you need to clean, warm, and humidify that air. Now, cleaning's not the hard part. Most ventilators have filters and they're delivering medical grade gas, right? The warm and humidify is going to be the big part here, because if we give dry, cold air to the lungs, the lung tissue is not going to like it. You're going to have mucus that's in your lungs that's going to start to dry out. And as it dries out, it's actually going to increase in size, and then it's going to get really sticky and it's going to block part of their lungs. So there's a very dangerous situation that can happen if we don't warm and humidify the incoming air. I remember getting called to go lecture at a place in Wyoming, and they had a patient with a tracheostomy tube that had a mucus plug that developed on them, and then they ended up demising. And so they asked for trach education. So I was part of the team that flew out there And we talked about tracheostomy tubes and how to just basics of tracheostomy tube care and troubleshooting and all that. And it turned out that they had this patient on nothing that would humidify and warm the incoming gas. And what's one of the primary functions of the upper airway is to warm and humidify the incoming gas. And what happened with this patient, she ultimately had a mucus plug that developed, and it blocked off her throat. It blocked her from breathing, and they couldn't get her back from it. It caused her to go into hypoxemia, right? And she could not come back from it. Her heart stopped, and she did not make it. And this is one of the big things. If they would have warmed and humidified, if they would have been there and known that the conducting zone is being bypassed, right? That we need, if the conducting zone is being bypassed, that means we absolutely have to make sure that the air is clean, warmed, and humidified that we're giving to that patient. Otherwise, bad things can happen. This side view, I like showing the side views. There's tons of these. I like to pull stuff that's not in your book, so it just sort of gives you a fresh perspective. This is a pretty handy slide because it also shows your turbinates, your concha, right? Your nasal concha or your turbinates. Go to purple. Nasal turbinates or nasal concha. These are going to be pretty important when we start talking about things like nasal intubations or nasal airways, when we're going into the nares, and then the types of first third of the airway, and then the posterior 2/3 of the airway, what type of cells line those. This is going to be very important where the epiglottis is, why the epiglottis is important. So this is going to be a very handy slide for you to pull out and sort of get a good visualization of what we're talking about. So if you have this sort of pulled up to the side while we talk about some of these structures, and I'll try to show pictures as we talk as well, it's going to be pretty handy. But this is all conducting. This is all dead space zone, right? We're going to filter, heat, and humidify, right? Starting with your external nares, you have things called vibrissae in there that sort of those nose hairs that sort of filter out big particles. And as you get in there, it's going to be the posterior 2/3 is going to be pseudostratified, right? It's going to be something that heats, filters, and humidifies. So we're going to get into all these areas, and this is going to be a very helpful thing. Even the sinuses, you can sort of see the different sinuses, and we'll get into their purpose as well. So as we get into the upper airway, so let's just start with the upper airway. I know we're already this far and we haven't made to upper airway yet. Is made up of, the first place is going to be your nose. It's supposed to say nose, but I'm just running in there so that we sort of know that that's what goes in there. It's supposed to be your nose, your oral cavity. Your oral cavity is considered part of your upper airway. Some people, especially if their nose is clamped off, their oral pharynx will act as a way to get gas into their lungs. Now remember, babies that are 6 months old or less actually are what's called obligate nose breathers. And therefore, their primary function of breathing is actually through their nose. So if you ever have a kid or a neonate that comes into the emergency department, let's say you're an RT working in an emergency department, you have a baby coming in respiratory distress, one of the first things that you might do is actually suction their nose. Because if they have a lot of stuff that's clogging up their nose, they're not going to breathe very well, because their mouth, until they're about 6 months old, their mouth is for suck swallow. It's for eating food or milk at that point, right? And so the oral cavity is an alternate airway. When we get down through the oral cavity, we'll get into the pharynx. Pharynx is P-H-A-R-Y-N-X. And once again, that's what goes in this third dot. P-H-A-R-Y-N-X. So that's the pharynx, and this is also known as the throat, right? So when we're talking to patients, we won't say things like oro and the laryngopharynx, we'll say the throat, right? Just to sort of keep it simple for them. And then when we'll get to the last one, which would be the larynx, L-A-R-Y-N-X. L-A-R-Y-N-X. Yeah, Y-index. So those are the upper airway sort of areas. The larynx is what some people would call the voice box. You are not allowed to call it the voice box in this class. However, if you're talking to a patient, you can say, oh, so that's sort of in the throat area where their voice box is. We call it the larynx, and that's what's going on, right? Now, let me ask you this. This is a sort of a good recall question for where we're at. What is this? Is this considered conducting zone, or is this considered respiratory zone? The naso-oral pharynx and larynx. Are these considered respiratory zone, where it exchanges CO2 and O2, or they're considered conducting zone, where their whole thing is to clean, filter, right? To filter, transport, heat, and humidify. What's going on here? Is it transporting, filter, heating, humidifying, or is it exchanging gas with the bloodstream? Hopefully you answered these are conducting zone, and they're transporting, filtering, heating, humidifying, right? That's what we're looking at here. So these are all functions of the upper airway. The upper airway, all structures located above the glottic opening, also known as the vocal cords, are considered upper airway, right? So once we get below the vocal cords, that's when we consider it lower airway anatomy, right? Below the vocal cords, we technically entered into the lungs, right? Even though we're in the trachea, we're technically into the lung category. We're into the lower airway category. And this is where if we're doing things like medications or a procedure like a bronchoscopy where we go in with a camera, that's considered the lower part of the airway in the lungs, and we're going to adjust our procedures and our medicines based upon that. So that's why it's important to sort of know the border between upper airway and lower airway. So this is what we're looking at here. Here's the larynx. So if that slide before where we were talking about the nasal, oral, so on and so forth, is a little confusing, this is a good side view of it. So when we get through the nose, the nasopharynx, the oropharynx, nose, the nasopharynx, the oropharynx, the larynx, and then finally the larynx. You see it there where the vocal cords would be, and then anything below that would be the lower airway, because that's where the vocal cords would be. So this just sort of gives you another good side view. You can also see the frontal and the sphenoid sinuses in there, and we'll talk about the sinuses in a second, but this gives you sort of that side view of the vocal cords in relation to the larynx. The nose itself is the only externally visible part of the respiratory system. It is the only externally visible part of the respiratory system. The nose does so many things, and it's one of those things where you got to remember, if we're bypassing the nose, if we're bypassing the oropharynx, if we're bypassing the upper airway with a tube, that means we got to replace the function of the nose. The function of the nose, well, I'm glad you asked. The functions of the nose, and notice there's 3 primary functions that are all in yellow here. Let me switch this to yellow. The 3 primary functions, and there's 2 ancillary functions. So notice these 3 are in yellow, right? Those are considered the primary or life functions of it. They're necessities. And then the bottom 2 here that are just in white, these are considered luxuries. So luxuries down here, luxuries down here. The rest of them are considered necessities. So the function is the only externally visible part of the respiratory system. It provides an airway for respiration, which is a way of defining a word called conduction. Supposed to say conduction or conduct, right? It's a way to conduct air. It's the movement of gas from one way to another. So the nose provides that conduction. It provides that ability to transport overall. It also will moisten and warm incoming air. So its other function is to warm and humidify. So warm and humidify is going to be your other one here. That's going to be the big thing here. So what would happen if you go from a nice warm room to a very, very cold weather? Let's say it's -2 degrees outside, right? Let's say you go skiing in very, very, very cold weather. You go from inside the hotel to outside on the slopes. What happens with that cold weather, right? You can easily freeze a lot of the airway, and then you can have an issue where the gas that's getting into the lungs is not heated and humidified as much as it could be, and therefore can cause alternate things like a bronchospasm, where the smooth muscle in the lungs actually contracts, right? And that's sort of where people can get what's called exercise-induced asthma or cold-induced asthma, is the air is not warm and humidified, and when it reaches it to a certain point in their lungs, if the gas is still cold, if that gas is still dry, it will cause mast cell destabilization and actually send them into a whole spiral, eventually into a bronchospasm. All right, so the nose, it provides airway for respiration to conduct. It moistens and warms incoming air, and it filters inspired air. So this is saying it protects, right? It forms some way of protecting. Let's say there's a construction zone going on, and there's tons of dust and concrete residue in the air. Well, what is some of the purpose of the nose? Well, it's going to trap some of those particulates. It's going to hold it in there, so that way you don't get it all the way down and clogging up your lower respiratory system. It's going to stop it and collect it in your upper respiratory system, where it can get rid of it, right? So protection is a big key here. Ultimately, right, so now those are your necessities. Your necessities are to conduct, to warm, humidify, and to protect, right? Those are your necessities. That's why they're in yellow. Conduct, warm and humidify, and protect, right? Other things that are luxuries that the nose does, and you know this, if your nose is stuffed up, right, what happens to your speech, right? It changes your speech, because the nose serves as a resonating center for speech, right? For talking, for speech. Speech, right? It's supposed to say speech. So when you're looking at this, of course, it's going to affect someone's ability to talk and speak. And then when it also holds or houses the olfactory receptors, O-L-F-A-C-T-A-R-Y. This is the olfactory or the smell receptors, if you want to write smell there, right? The smell receptors. And so these are luxuries, right? So you know if someone's nose is stuffed up, they're not going to be able to taste food very well. And in fact, people that wear oxygen chronically tend to actually over-season their food quite a bit. They put a ton of salt and seasoning in their food because you have oxygen running into their nose all the time. So their ability for scent molecules to dwell in their olfactory centers is actually reduced, and so they actually tend to over-season food so they can actually taste it a lot better. So that's kind of interesting, right? So let me ask you some review questions before we move on, right? This is if you need to pause and go back, right? Some review questions before we move on. What are the three functions? What are the three primary functions of the nose? Right there in front of you here. What are the three primary or necessity functions of the nose? What are the three parts of the upper airway? Next question. What is cellular metabolism? What is cellular metabolism? What's the difference between external respiration and internal respiration? What's the difference? How does respiration work? What's the order of operation? We inhale what? It goes where? How is it transported? What is tidal volume? Right. If you're struggling with those questions, I encourage you to actually pause here and go back, look over that stuff, make sure you got it down before we go into more stuff. Take breaks. That's the advantage of this being on YouTube, is you can speed it up, you can slow it down, you can pause it, you can come back to it, but do that. All right, let's go into just the functional anatomy of the outside of the nose. This is a skeletal framework, and so you might have already covered this in regular anatomy and physiology. The nasal bones, the nasal and frontal bones are superior, so that they're around the forehead. So these are the nasal bones up here. I'll switch it to purple. The nasal bones are up here. Right, and so when we're looking at these, they're superiorly. Maxillary bones are considered laterally, so this is with the frontal process of the maximal. So those are the lateral ones. Why do I need to know this, Derek? Well, let's say someone has a trauma to the face, like a airbag that breaks their nose. Could that obstruct the ability to get oxygen into their body? Absolutely. Right, could blood be going into the airway? Absolutely. Right, so there's a lot of stuff that does have application here. The plates of the hyaline cartilage, the lateral, septal, and alar cartilages are considered inferior, right? These are considered lower or inferior, right? Not in their function, just as far as orientation goes. And that's just, hey, that's where these are located, right? So I'm not going to stress this too much on you, but it is something that you do need to be aware of if something's superior, lateral, or inferior. Inside and posterior, so inside and behind the nose, the external nose. So this is sort of behind that out part, right? So this is beyond what we see, right? This is on the inside. And here's a sagittal picture, right? So this is beyond this front part of the nose. So what's behind this front part of the nose? If we were to cut the nose off, right, what would you see? Right, and that's what we're looking at here. It's divided in midline by the nasal septum. Nasal septum should be that first thing there. Nasal, let me go to yellow. Nasal septum. Right, nasal septum. So this is formed by the septal cartilage. I'm glad they did that way. And posteriorly by the vomer bone. It's supposed to say vomer. I'm going to need to get a new stylet here. And posteriorly by the vomer bone. The vomer bone and the perpendicular plate of the ethmoid. Now, if you're like, how do I spell that? It should be in your chapter, right? That's where I got all this information from. I can't, my stylet's not very great, so I'm doing the best I can with it. So the vomer bone and the ethmoid bone are what sort of are in this area here. So when you look at this past this cartilage, the cavity gets back down, goes back down, contrary with what you might think. It goes continuous with the nasal pharynx into the nares via the internal nares is what we have inside here. So the roof is formed by the sphenoid bone, SPH, so that's what I'll just put an S in there and then spell it for you, sphenoid bone, SPHENOID, right? So the roof of the nasal cavity is formed by the sphenoid bone and the ethmoid bone. And I'll spell that one, ETHMOID. Okay, So why am I talking about the nasal cavity? There's actually lots of things that can go on here, and one of the ones that first comes to mind is there's a procedure that we do called nasotracheal suctioning. That's where we're actually going to take a catheter, feed it through the nose, go through the posterior part of the nose. So I'm going to do this in purple. We take a catheter, we go through the posterior part of the nose, and then hopefully into the trachea. And then we'll go through the trachea, and hopefully we stay above the carina the whole time, but we're going to go into the trachea, and we're going to suction out stuff that's in there. So this is done on a patient that might be semi-conscious, or a patient that doesn't have the ability to cough, but they have a lot of mucus hanging out right below their vocal cords. So we might put a catheter up through their nose and feed it down into their trachea, and then into a little bit deeper than their vocal cords, and go ahead and suction them out. So this is something where we need to know the anatomy, because when we go to put this catheter in, do you want to put this catheter straight up and hit the top of the nasal cavity where the olfactory sensors are, where the a lot of more vasculature is, or would you like to stay lower and avoid all those bad things? Well, we want to stay lower and avoid all those bad things. What if they have to intubate? Let's say someone's jaw is broken off, right? A severe trauma patient, a gunshot victim, right? Their jaw is completely taken off, and we can't put a tube through their mouth into their trachea, but we can put it through their nose and into their trachea. But we want to stay low. We want to avoid the roof of those bones, because then when we hit those bones, it's not going to be very likely to turn around and go down into the trachea, right? We want to stay low. So there is some application just off the top of my head for this information. All right, this is a different picture. This is looking at it sort of from a side view. Once again, this is where you can actually see that cribiform plate of the ethmoid bone that's up here. Right, this is that cribiform plate that you're looking at up there. Then you see your frontal sinus here. I'll just write the F for frontal sinus. And then here is the superior area of the nasal cavity. And down here at the maxilla, this would be the bottom or basement or inferior part of it. So when we're suctioning, we want to go low, or when we're putting in the tube, we want to go low, so we avoid all this, the perpendicular plate or the cribiform plate of the bottom of the skull there. So we try to avoid that as much as we can. When we get back here, I want to just highlight these real quick. See these two? This is the sphenoid sinus, so these two cavities that I just highlighted here. That's the sphenoid sinus. And then, of course, those are on top of what's called the sphenoid bone, which is I'm highlighting now, right? That's the sphenoid bone, right? And these are, the sphenoid bone is considered superior part of the nasal cavity. So all this area is considered superior part of the nasal cavity. And we want to try, like I said, to avoid these areas. The vomer bone in this picture would be considered lateral. So that would be like the far side of the wall. I wish I had a 3D object for you guys to actually handle and physically connect to, but unfortunately this is what we got for right now. So this is just sort of a different way of looking at the sinuses, the cribiform plate, just sort of giving you a different picture of the things that we just talked about on that last slide. Right, the nasal cavity, the floor is formed by the same bones as the hard palate. So the hard palate and the soft palate is two things that we're going to be looking at. Here's the soft palate, and then here's the hard palate, right? One's bone, one's not bone. So the floor is formed by the same bones as the hard palate. The hard palate, which is the first thing here, switch to yellow. So the first line there should say hard palate. The hard palate contains portions of the maxillary bone and the palatine bones. Right? So that's going to be the hard palate to start off with. And then towards the back, we'll get to the soft palate back here. The soft palate lacks bone. but it's very flexible, and it has a mass of collagen fibers. So it is a lot of collagen, and this is good because this little flap ultimately can go to what's known as the uvula, or that little dangly thing in the back of the throat. Why do you care about the uvula? The uvula is going to be, this is going to be the soft palate. The soft palate. The uvula is that thing that sort of closes off the nasal pharynx when you're drinking and eating, and it prevents food and water and milk from going up into your nose while you're eating and drinking, right? And when you're breathing in, then it moves downwards to allow gas to go and flow all the way down into your lungs. So you need that sort of soft palate to help the airways function, to close off during eating, drinking, and to open up during breathing. This is why if someone's laughing and drinking milk, they can actually come up through their nose, right? Because that soft palate, that uvula that hangs out in the back there, is open, and therefore that milk can come right up through and out. There you go. Protruding medially from the nasal cavity, each lateral wall of the nasal cavity, there are 3 bony conjunctions, or projections, called the superior, middle, and inferior concha, right? The concha. They're also known as the turbinates. So you might see those synonymous with each other. So on this picture over here, I'm going to try to highlight it for you. Superior, middle, and inferior concha. You see those 3 little sort of projections? They have a lot of purpose, and that's what we're going to go over here. They're important because they increase, and I'm just going to draw an up arrow, they increase the mucosal surface area. Why is this important? I have a lot more mucus in contact with the gas that I'm breathing in. That means I can trap pathogens, I can trap dust, I can trap bad things that aren't supposed to go into my body and get rid of them before they go into my lungs, right? A virus or a bacteria, I can trap those there and stop it from going into my lungs. I can trap dust, I can trap all those bad things. So it's very important that they increase the mucosal surface area. Not only that, but with increased mucosal surface area, we have an increase in humidity. That's right, it helps humidify the gas because there's more mucus in contact with it. What do you know? The primary constituent of mucus is going to be water, right? And so that's what's going to help there with humidifying the incoming gas. And then they also increase surface area big time. Why is surface area important? Well, the more surface area there is to trap the mucus, the better. And that's what we talked about here, the increased mucosal surface area. What do you think they do to the gas? So this comes to your chemistry and physics class. What type of gas flow do you think the turbinates create? Is it turbinate, transitional, or laminar gas flow? Well, it's going to create, on purpose, turbulent gas flow. You're like, why is that? Because remember, turbulent gas, does it move fast or slow, right? So it gets caught up here, and it's just going to spend a lot more dwelling time here because it's turbulent. So it's going to bounce against all these walls. So it gives you a longer time, or what we call a longer time constant. It gives you a lot longer time for that gas to dwell in the nasal cavity. Well, what's the importance of that? The longer it stays in the nasal cavity, the better chance it has to heat, filter, and humidify the gas before it travels into your trachea, before it goes to your respiratory system, right? Before it makes that journey into the respiratory system. So by making it turbulent on purpose, we actually improve the effectiveness of the upper airway. We improve the function of the upper airway. Right? Alright, so let's move on. So the groove inferior to each concha is called the meatus. M-E-A-T-U-S. I'll just put an M here because I cannot spell it with this stylet. M-E-A-T-U-S. The inferior groove to each concha is called the meatus. The nasal cavity is surrounded by a ring of paranasal, and we already talked about these, sinuses, which are located in the frontal, sphenoid, ethmoid, and maxillary bones. So when we're looking at this from the side view, the purpose of the sinuses is really ultimately unknown. We know that they have some advantages. So some advantages is they help humidify the air that we breathe. So that's a theory, right? We know that they have that ability to help humidify. We know that they help absorb blows to the head for trauma, which is a very nice thing to have because you want to keep your brain as healthy as possible. We know that they make the skull lighter. We know it makes the skull ultimately more efficient in its weight when we're looking at the skull altogether. We know they resonate sound, right? When someone has a sinus infection, when someone has their sinuses full with mucus, we know that that resonation of their voice, it changes. So it does change the way that they sound. We know that it can actually help trap pathogens as well. It has some immune properties to it. So even though the function of the sinuses overall is unknown, right? The purpose of the sinus is unknown. We know that they have very adventitious functions. I don't know if that makes sense. So we don't know the true purpose, but we know that it has a lot of function, which is very good. All right, so as we're looking at this side picture that I already drawn on, air enters, it splits into separate streams, right? We got the superior, middle, and inferior concha, and then that exposes that inhaled gas to mucus and blood vessels, and then it should be getting close to 100% heated, body temperature, pressure, saturated. BTPS. It should be pretty close. Now, I'm going to talk a little bit. In your Egan's book talks about it. It does not talk about it in your Desjardins book. So if you want to look more about this, look at your Egan's book. This is a rough picture of what I call the carina. So this would be the trachea, and this would be the left and right main stem bronchi. And this will make sense as I'm talking about it. When we get into the lungs, by the time the gas gets roughly 1 centimeter below the carina, 1 centimeter below the carina is what we call the ISB. Isothermic Saturation Boundary. That's what the ISB stands for. That means by the time the gas gets from your nasal cavity, your pharynx, your larynx, into your trachea, and then at least 1 centimeter past your carina, the gas should reach, and this is something that we can't see on microscope or anything like that. So the ISB, once it gets there, it should reach 100% temperature and pressure. Right, we should get 100% humidified and at body temperature, pressure saturated. That's where the function of everything should have gotten this gas to be at body temperature and humidified by the time it gets 1 centimeter below the carina. So that's your isothermic saturation boundary. Like I said, your Egan's book actually talks about this. It's not in your Desjardins book. I will ask you to recall this information, the isothermic saturation boundary. Why? Well, what happens if this gas is not humidified? What happens if it's dry gas? What happens if it's cold gas and it gets down here? Right? So that cold gas gets down here into that left main stem, way past the isothermic saturation boundary. Well, the little cells that are inside the lining of the airway, they have mast cells that will destabilize, and when they destabilize, they can eventually cause bronchospasm, or the smooth muscle in the lungs to constrict, and that can block off the ability to breathe. So this can actually cause an asthmatic response or reactive airway response. And so that's why people that have cold-induced asthma or exercise-induced asthma, they're breathing so fast, or the air is so cold that it's not humidified and heated by the time it gets to the ISB, that they actually go into a bronchospasm, and they have to use a bronchodilator, right? They have to take some puffs of their albuterol or something like that to help them overcome that situation. right? So that's where this sort of comes into play, and that's why I wanted to sort of talk about the ISB here. But the nose should have most of this work done, right? Because we're spending a lot longer time in there because of the turbinates, also known as the concha, increasing the dwelling time for that gas. This is a front picture. I like this picture a lot. I know it looks a little freaky to you. You can see the eye sockets here, right? And so we have the numbers here, and the numbers sort of correlate to different areas. Number 1 up here is the frontal sinus. So you can just sort of see that area here, and then over here. I'll just draw it on the other side too. Looks like I made this person angry with the eyebrows, but the frontal sinus is what you're seeing there. So that hole there, that's where you see if people get that sinus pressure way up there, that's where that frontal sinus is compared to when we're looking at number 2, which is our next one. This is the maxillary sinus. So maxillary sinus, those are the ones where people might feel pressure underneath their eyes. This area can be also damaged with trauma, blows to the face for sure. When we get to number 3, this is the superior concha. Superior concha. Now I'm going to go a little bit out of order here on purpose, and you'll hopefully see why. Number 3 is your superior concha, so it's the uppermost, so it's the closest to the olfactory center, the smell receptors, all that stuff up here. Number 5 is the middle concha, and that means number 7 is the inferior concha, right? So we just seen those 3 projections in the nose that help turn the gas to turbulent, help increase surface area, increase dwelling time, increase filtering, increase humidity, right? All those good things, that's what they do, right? So the superior, middle, and inferior concha. If we're going to put a tube down up someone's nose and down into their lungs, which concha do you think we'd want to go through? The superior, middle, or inferior? Which one has the most space, right? That inferior concha right there. So we'd probably want to go as close as we can to the septum back there, because that's where we have the most space and we're less likely to cause damage. So hopefully you see why I went 3, 5, 7 there. Number 9, just going from left to right, I guess. Number 9 is the nasal septum. All right, this is that thing in the middle here. Some people choose to get that pierced, right? I don't, but that's that nasal septum in the middle that puts that there. And then over here, 4, 6, and 8. 4, 6, and 8 are the bottom parts of the concha. Do you remember what they're called? The bottom parts of the concha are called the meatus, M-E-A-T-U-S. So number 4 is the superior meatus. Number 6 is the middle meatus. And I'm trying to highlight these as we're talking. The middle meatus, and then number 8 is the inferior meatus. So this just sort of gives you that good picture of what's going on there. All right, so this is just a different picture from the side, and I like this one because it does sort of show, let's go to purple here, sort of show what they look like. Number 1 up here, superior concha, number 2 middle, and then number 3 inferior. You see how there's much more area under the inferior meatus for passing a tube or a catheter, and that's why we're stressing this so much, or that's why I'm stressing this so much. It gives you a different perspective on it, plus it also makes more sense. If we're going to do a procedure that goes through the nose, go low and go towards the septum, right? That hug the septum, right? And then go low because there's more space there. All right, so how does the system function? Well, air enters the nares into a dilated area called the vestibule. Oh heavens, go to yellow. Vestibule, V-E-S-T-I-B-U-L-E. V-E-S-T-I-B-U-L-E. Right, so the vestibule is that first area that it goes into. The vestibule is lined with hairs
These are your nose hairs, and these are called, and start with the V as in Victor, right? The V, and they're called vibrissae, Vibrissae. Once again, vibrissae, Vibrissae. Those are your nose hairs, right? Next time you see your nose hairs, you're like, hey, my vibrissae are there. I always remember this because I always think of Febreze, right? That little spray thing that makes your clothes smell a little bit better, right? And then Febreze with a V instead of an F, right? Vibrissae are the nose hairs that protect against large foreign particles. So their purpose is to protect. I might ask you down the road, like a test question or something, right? I might ask you, what's the purpose of the vibrissae? You'd be like, protect, right? That's the one that you'd want to pick. I'd be like, to filter, heat, humidify, and you'd say filter, right? They're a protection mechanism, right? So those are your first protection mechanism, is the vibrissae, and that first third, also known as the vestibule, right? So the first third of the nasal cavity, and we talked about the first third and the posterior 2/3, we're going to separate them out because the first third doesn't have the same type of tissue as the posterior 2/3. The first third of the nasal cavity has stratified squamous epithelium, right? So very, very thin epithelium, because it has vibrissae to get those large molecules, those large particles, the large dust particles and so on. It doesn't need to have complicated tissue. So it just has that there to block the big stuff to begin with. And as we go back, and that's the next point, the posterior 2/3 is lined with pseudostratified ciliated columnar epithelium. So I just shorten this up as P, pseudostratified. So PSCC. So pseudostratified ciliated columnar. Pseudostratified ciliated columnar, right? That's what I have there. So you can write out the whole thing if you want. I'm just going to write PSCC. That means pseudostratified ciliated columnar epithelium, right? So I think this is, I believe, page 11 in your textbook. You might have a different textbook than I have. But remember, this whole point is the first line of defense ultimately is going to be your vibrissae that's in your vestibule. And once it gets past there into the posterior 2/3, that's when you're going to get into your pseudostratified ciliated columnar. Remember, this area has cilia and mucus that also can protect, right? As well as start the humidify process. So this is a pretty good situation. So how does the system function? Well, when air travels through the turbinates, right, when it goes through those concha, it's going to separate them into streams, and it allows for, and what of surface area? Do you remember? Said it before. It increases surface area, right? Because we're having that curvature, we're adding to that surface area. And this increased surface area increases, you ready for this? The temperature, so I'll just write a T in there, the temperature of air, and adds, everybody's favorite word, moisture, right? It adds humidity, right? You can put humidify in there if you want. So increased surface area increases temperature and moisture or humidity right in there. So it's going to help that gas get conditioned before it gets to the lungs, right? That's the first area that it's going to start the conditioning. And because of increased surface area, it's really going to help not only filter, but also increase the temperature and the water content of the gas, which is going to help our lungs function that much better. So the second function is to warm and humidify. Remember, the first function was to filter or protect, right? So our first function is to protect. The second function is to warm and humidify, if we're going back to those points again. The nasal cavity itself, we already talked about this a little bit. So repetition's the key to learning, and here you go. I'm going to repeat myself on purpose, and notice the things that I repeat. The first one here, the line number 1, is stratified squamous epithelium. Stratified squamous epithelium. So this is a very thin, right? They're sort of stacked like bricks. So if I draw rectangular bricks, Yeah, I should have gone to the Art Institute. But then I wouldn't get to talk to you guys. That would have been bad. All right, and I'm going to nuclei. Why not put nuclei in there? Everyone deserves a nucleus. All right. So stratified squamous, this is the best drawing I can do of it. So congratulations. So when you're looking at this, it's stacked like bricks. So if you have to look at something like this under a stethoscope, not a stethoscope, a microscope, that's what you would see. It's very thin tissue. It's the anterior thirds. It's non-ciliated. It's in the vestibule. And it's also in the oral cavity. Now, you're like, Derek, there's a lot of different types of tissues in the upper and lower respiratory zones. Yes. However, one of my requirements for the class, and it's not my requirement, it's a school requirement, is that you know the types of tissues in each part of the respiratory zone. So the idea here is to, if I ask you what type of cells are in the first third of the airway, you'd say stratified squamous, which is in the posterior 2/3 of the nasal cavity. You say pseudostratified ciliated columnar. What if I say what type of cells line the oral cavity? You would say stratified squamous epithelium. What if I said what type of cells line your trachea and your bronchi? You'd say pseudostratified ciliated columnar. So you need to make a list of sort of what cell types are where. Now, the easy way to remember this that I had when I was in school was if food can go through it, right, then it's going to be stratified squamous, right? So we're looking at the oral cavity, so the oral pharynx, the mouth, the oral cavity, those are all going to be stratified squamous, right? When you're looking at PSCC, which is the second one, pseudostratified, if this starts to write, ciliated columnar, is the 2/3 of the nasal cavity. This one has ciliated, right? Hence the cilia part, right? And it rests on the connective tissue layer supplied with mucus and serous glands. So it has mucus and serous glands. Mucus-producing goblet cells are dispersed among the pseudostratified ciliated epithelium cells. And so when we're looking at this, it has a bunch of mucus. So if I ask you down, in the future, like on a test question, if I ask you about what type of cells are in the oral pharynx, does your mouth, does it have goblet cells? Does it make mucus, right? It has saliva, but does it make mucus? Does your mouth make mucus? Does it have hair, right? The cilia is hair, right? Little hairs. Do your mouth have those little hairs? No, right? So don't pick pseudostratified ciliated columnar, right? That's where you're looking at your stratified squamous. So when you're looking at stratified squamous, it's going to look a little bit different. Stratified squamous, you're going to have sort of this very tall, almost columnar. Then I'm going to draw this guy. And then it's ciliated, so it has all these little hairs on it. Those are supposed to be hairs, if you haven't guessed. And then this is supposed to be submucosal glands down here, so this is where it's making mucus. And then here's a goblet cell, and I try to do a fancy thing that looks like a goblet or a drinking glass here, right in the middle, if it wasn't plainly obvious to you. So that's what you got going on with pseudostratified ciliated columnar. It looks a lot different from up here in the stratified squamous. So this is your PSCC down here, and this would be your stratified squamous up here. Remember, in your oral pharynx or in your oral cavity, right, you don't want hair in your mouth. So it's not stratified squamous. That's another way I remembered it. But just sort of looking at the difference there, sort of get you to see it's layered and it makes mucus and it moves things along. That's not something that your oral cavity does. So keep in mind, some people do well
just understanding that, and other people have to make a flow chart with what type of cells are. On this one, I will sort of change this from English units. Your nasal cavity does produce a lot of mucus, and it's approximately 1 to 1.5 liters, right? I'm changing the units. It's not a quart. Quart's like 900 mLs, all right, so that's less than a liter. Most of your nasal cavity produces 1 to 1.5 liters of mucus per day, right? Per day, 1 to 1.5 liters. It's a lot of mucus. Well, why is the picture there, right? The picture's there, A, to gross you out, because most of this mucus that your nasal cavity makes goes into your stomach. Oh, heavens, right? So when we're looking at the cilia, remember me drawing that cilia picture, right? Then your goblet cell, then your cilia. Right, remember ciliary beat instead of motility in your nose, right? So we're assuming this way. The cilia actually propel the mucus towards the oropharynx in your nose. And when you're in your oropharynx, then it would go into your esophagus and then into your stomach. So most of this mucus you're actually swallowing is going into your stomach as far as digestive system goes, right? So this is a beneficial thing, because instead of the cilia moving out and coming out the front of your nose, where you'd constantly have all this dust and particles and bad pathogens coming out of your nose, it actually goes into your stomach, which has an acidic environment, hopefully, and can actually kill pathogens and all that stuff more effectively than it just sort of sitting out in your mustache or whatever, right? So when you're looking at this, it's a lot more effective that the cilia actually beat towards the oropharynx than actually come back out. So when I talk about this, I try to make sure, so when it's really cold outside, what happens to your nose? Do you start to get your nose where it runs when you go outside and it's really cold out, or you go skiing and you see those people that do have beards and mustaches, right? And there's a bunch of musicles that have formed on their nose, under their nose. That's because the cilia actually get cold and they get stunned and they stopped moving. Therefore, if you're outside and it's cold and your nose starts to run, that's because the cilia froze, or the cilia stopped moving, and all that mucus that your nose is creating is actually going forward and out through the front of your nose instead of going into your stomach, right? Pretty crazy. So next time you're outside and it's super cold and your nose runs, you're like, oh, my cilia, right? Cilia stopped working. That's why some people will wear those masks with that cover their mouth and their nose when it's super, super cold. That actually can help avoid this, because then the cilia sort of retain that heat part to it, right? So you make a lot of mucus, 1 to 1.5 liters. I may ask you to recall this information at some point. And that's going to be an approximate value that you make, and most of it you swallow, but that's what your nasal cavity produces. So what's the difference between mucus and sputum? So you're going to see these two different terms out there. Mucus is a slippery secretion of the lining of the mucous membranes of the body, just in general. It's produced by goblet cells that cover the surface of the membranes. Pretty straightforward. You've seen my drawing of goblet cells. Sputum, however, is the stuff that's coughed up from the respiratory tract. Now, this has been termed mucus or phlegm, and it's mixed with saliva, and then it's expectorated from the mouth. So sputum is actually a German word that means from the mouth, right? And correct me if I'm wrong, but that's what I've been told, actually. So sputum is a German word that means from the mouth. And so when we're looking at this, this is something where it's been mixed with its secretions, or phlegm from your lower respiratory tract. It's mucus from your lower respiratory tract that is then mixed with saliva that we put into a specimen container, right? So if a doctor orders a sputum sample, that means we're going to go into the room and have the patient
cough and spit up a good sample of mucus from their lungs into this whole container here. And then we're going to send that to the lab and say, enjoy, lab. So we're going to have that in there. But the thing with the sputum sample is it's mixed with saliva. What if I have an upper respiratory infection, right? What if I have a nasal infection? What if I have that going on and some of it's sort of showing up in my saliva? Well, how do I know if it's spread to my lungs or not if I'm doing a sputum sample? Well, a sputum sample is mixed with saliva, and therefore it could give you a false positive that there's something going on in the lungs. So the doctor may order, hey, I want what's called a tracheal aspirate, right? This means we have to go and bypass the upper airway with the suction catheter, like nasal tracheal suction, right? Bypass the upper airway and then suck out a sample from below the vocal cord so it's not mixed with saliva, and then send that sample to lab to evaluate. That's going to give us, hey, what's specifically going on in the lungs altogether. A sputum sample, however, just says, hey, it can be mixed with saliva. It's okay. That's not going to affect how we're going to treat them. So it's important you sort of know the difference between just a sputum sample and a tracheal aspirate, because it means you doing something different at the bedside, right? It means, one, you're just having them cough up a good sample into a container and you're labeling it and sending it. The other one you're going to have to do an invasive procedure for. Alright, so let's talk a little bit more about mucus. Mucus is produced by the goblet cells, of course you already know this, and submucosal glands. It's made up of salt and water, and it also contains lysosomes. So what are those? Hopefully you remember, but if you don't, these are digestion organelles that work to break down proteins. So they help break down some material that can be collected into the lungs or into the areas that have these mucous membranes. So when we're looking at this, that lysosome can be an important protection mechanism. There. So when you hear people talk about phlegm, phlegm is a type of mucus. That's what goes in that blank there. Type of mucus that is restricted to the respiratory tract. Term mucus just refers to secretions of the nasal passages as well. So if someone's like, hey, did you see that the color of the mucus? Well, hey, that could be upper respiratory, that could be lower respiratory. When say, hey, did you see the color of the phlegm? Then that usually implies the lower respiratory tract, right? So it's restricted to the respiratory tract altogether. So that's when you're hearing phlegm that is coughed up into the mouth. That's what sputum is, right? It's phlegm, right? It's mucus of the respiratory tract that's coughed up into the mouth. So phlegm is a more specific term, and that's why we like it. That's why we'll use the term, hey, their phlegm looked green, or hey, their phlegm looked red, their phlegm looked frothy, right? So these are all things that we'll refer to as far as phlegm goes. It's very specific to lower respiratory tract. That's why we like it. That's going to be something that's going to come in very handy for you to use it. But remember, a sputum sample is phlegm that is coughed into the mouth to check for cells and infection, things like that. Mucus overall has a high water content. Supposed to say H2O there, but it's not working. Has a high water content that humidifies inward air. So if your mucous membranes dry up for some reason, antihistamines or dehydration happens, then you're not going to be able to humidify incoming gas as much, which means you have a higher chance at mucus plugging and other alternate things like mucus bronchospasm, right? So we like the high water content of mucus. That's why we need people that have obstructive pulmonary disease like emphysema to stay well hydrated, because if they have a mucus that plugs up part of their lungs, they already have a baseline difficulty of breathing, and that's going to make it even more difficult for them. And so they need to stay well hydrated to help keep their lungs functioning well. So humidity is a very important thing for everyone, and especially for those patients that already have lung issues, right? So the ciliary current, or the ciliary beat, right, moves mucus towards the pharynx, or the throat if you want to write throat there, but the pharynx, P H A R Y N X, right, towards the pharynx for swallowing. So the cold temps will disable the cilia. I already talked about this, where that's why your nose gets all runny when it's cold out, because the cilia is no longer moving the mucus towards your oropharynx. What about your lungs? Well, hopefully the cilia is moving things up and out towards your oropharynx, right? So the idea is to eliminate it in some way, whether it's eliminating it into the stomach acid ultimately, or out of your mouth as far as sputum goes, right? So ciliary beat should go towards the pharynx at all times, or towards the mouth at all times. Sounds like that's something that I can ask you in the future about, ultimately. We have a lot of rich network of capillaries and veins that are in the nasal epithelium that also warm the incoming air, right? Nosebleeds, have you ever seen how massively some of these nosebleeds can have? There's a lot of vascularity in there, and that's important because that vascularity helps heat the air that they're inhaling, right? Because remember, one of the functions of the nose is not only to filter and humidify, but also heat or warm the incoming air. And the more blood vessels there are, the more vascularity there is, the more surface area, the better the chance of ultimately getting that heated up before it gets to the lungs. Right? It humidifies, it has a high water content, it moves it towards the pharynx, and it has a rich network of capillaries. Notice that I sort of made a big repeat there. That's important. All right, so at this point, take a break if you need to, pause it, right, come back. Here are some questions for you, okay? What is the purpose of the concha? Right, this is just a quick review in the middle of this whole thing. I love doing these break and reviews, right? What is the purpose of the concha? Why? What do they do? How many concha are there? What's the inferior part of the concha called? What are the two types of epithelium cells in the nose? What's the first third? And what's in the posterior 2/3 of the nose, or the nasopharynx? Another application question. What's the difference between mucus, sputum, and phlegm? And then last one, and you can peek at the screen if you want to. What is mucus made mostly of? Right, so those are some things. When you get into things like pharmacology, especially advanced pharmacology, we talk about things called mucins. Mucins, and we talk about the different type of things that we can do to thin out mucus. Good humidity, good body humidity is always a great way for that as well. So making sure a patient's not dehydrated, or making sure a patient is hydrated, is a great way to start off making sure they're making proper mucus. All right, let's go to the oral cavity. The oral cavity is considered an accessory respiratory passage. In other words, it's not a primary. Like I said, babies that are 6 months old or less are what's called obligate nose breathers. That means that you're born mostly breathing through your nose, because your mouth is not for breathing. When you're born, your mouth is for drinking milk, right? It's for a suck swallow, right?
So the accessory passage, which is the oral cavity, is lined with stratified squamous epithelium, right? So I'll just put stratified squamous epithelium here, right? So that stratified squamous does not have hair, right? It's non-ciliated, right? And it ultimately is going to go down into where you don't want hair in your mouth and you just want it super, right, just basic there, because that has food and liquid that pass through there, and so it's not going to function well there because it's an accessory passage. It's not a primary that's there for filtering like your nose is, right? So air enters the vestibule, right, the outer portion between the gums and the lips, and moves into the large opening that extends to the back of the oral pharynx. And that's where you're looking at the stratified squamous. Ultimately, the roof of the oral cavity, so this is just defining the oral cavity. The roof is made up of the hard palate. It's supposed to be an HP, but there you go. This is going to be your maxillary and palatine bones. So the roof of the oral cavity have the maxillary and palatine bones. Then it's going to have your soft palate, right? That's that soft posterior part, which is made mostly of, and you talked about a lot in A&P, collagen, right? So it's made mostly of collagen. And then you finally have the back part, the very back part, and I've actually already talked about it. It's called the uvula, U-V-U-L-A. The uvula is that soft dangly thing at the very, very back. And then even people that have obstructive sleep apnea, where part of the airway collapses when they sleep, they might actually get to a point, if the uvula is part of the obstruction, there's a procedure out there called the UPPP. So it's the uvulopalatal pharyngeal plasty, right? That's the removal or fix of the uvula obstructing the airway. So that's even something they can get rid of to help someone breathe easier while they're sleeping, which is pretty cool. The soft palate of the oral cavity will actually rise and shut off, and we're looking at the uvula here, will rise and shuts off the passage between the nasal and the oral cavity. We already actually talked about this when I talked about milk and how it can come out of people's nose when they're laughing, right? So this is to help someone suck, swallow, and all that stuff appropriately. It closes it off so that way food and liquid won't go through the nose when someone is drinking or eating, right? And so the levator villi platinum muscle draws up and back. So it pulls it up and back. So here's the little dangly thing right in the back of your mouth. So it pulls it up and back and shuts off the nasal pharynx, that hole there, so that way food and liquid can go down into your stomach, right? So it closes it off so you can drink and eat without that stuff coming back up through your nose while you're swallowing or you're eating or you're drinking. That's the whole point. So this muscle here, right, that's what pulls it up. And the way that I remember this is the muscle that closes it off is this looks a lot like elevator. That's what we're looking at here. It looks like elevator. So it pulls it up and closes it off. So that's where I bring in the levator, right? And then the palatal pharyngeal muscle will pull it down and forward. And that's the motion of that muscle. It pulls it down and forward. So when we're looking at this, let me draw a separate box. And so we'll just do a whole separate thing here. The palatal pharyngeal, right, pulls the uvula down and forward, right?
And that's what's going to happen. So if we got the uvula here, it's going to go from being at the top of the oral pharynx, closing off the nasal pharynx. The palatal pharyngeal will move it down and forward. And then if we start to drink or eat something, then the levitator, right, that's not the full name, but the levitator is what I call it, moves it upwards and backwards, right? So your LVP moves it up, and your palatal pharyngeal moves it down and out. So PP goes down and out. Levitator goes up and back. I don't know if that's how you want to remember it, but that's sort of how I remember it. Sort of that box motion down forward or up and back to close it off. In your nasal cavity, you also have your palatine arches. So your palatoglossal arch, which is the upper one, and your palatopharyngeal arch, which is the lower one. So these are ways to protect the airway or to protect the oral cavity. And they contain tonsils and lymph tissue at the front, and they're a frontline protection of the body overall, whether you're eating or breathing, right? They can form a frontline protection, right? So these are your palatine tonsils. They're where you look for the white patches for strep throat. They're looking at those palatine arches right there. Okay, so this is just a different picture of what we were just talking about, the palatine arches, and you can see the tonsils in there, and that's what they're looking at for the white spots and all those things for strep throat. They're trying to see is that where the infection started. So this is just also anatomy when we're looking to intubate someone, when we're looking to put a tube into someone's trachea. We have to use the anatomy because one of the things that you use, especially if you're using a Miller blade or a straight blade, is the uvula is going to be one of our landmarks for that. And so we got to pay attention. We're also evaluating other things. There's something called the Mallampati scale. You don't need to know it for this class. And it's just looking at how many structures of the airway we can see, because the more structures of the airway we can see, that means usually the better view we have for intubation, or the easier in theory the intubation could be when we're doing evaluation of how difficulty or the level of seriousness someone's airway is in an emergency. So these are going to be very helpful to you to sort of get this down. All right, so we moved from the nasopharynx to the oropharynx, and now we're in the regular pharynx, or the throat. The throat is a funnel-shaped ultimately area. It's large at the top and then smaller at the bottom. It connects the nasal cavity, that's the next line here, connects the nasal cavity in the mouth superiorly to the larynx and esophagus inferiorly, and the esophagus inferiorly. And the esophagus, it sounds like I want you to know this, and I do. So you should know, and I will test you on this, I guarantee it. The origin, or sorry, where the nasal pharynx starts and stops. Where the oropharynx starts and stops. Where the laryngeal pharynx starts and stops, right? So you do need to know those borders. That's something I have to test you on. So the three regions of the pharynx from superior to inferior is going to be first the nasopharynx. I'm just going to write NP here. The nasopharynx, and remember the nasopharynx, which is the posterior 2/3, right? So it's this whole area here. The posterior 2/3, what's that lined with? Stratified squamous or pseudostratified ciliated columnar epithelium, right? It's lined with PSCC. So whenever you see this, that's just going to be good habit for you for when you do take the test, knowing which areas have what type of cells. You also have the oropharynx, which is this next line. The oropharynx have what type of cells? Now remember, food and water and all that stuff pass through here. The oropharynx have stratified squamous, right? Food or water goes through stratified squamous. Right, and then finally the Laryngopharynx, which is the last one, also known as the Hypopharynx. So if you ever hear someone call it the Hypopharynx, it's the same thing as the Laryngopharynx. They're synonymous. The Hypopharynx or the larynx should be there as different places. So the Nasopharynx, let me switch to purple. Nasopharynx is up here. Right? Your Oropharynx goes down here. Oropharynx. And your Laryngopharynx or Hypopharynx is down here. Right, so we're looking at sort of where those are located from the side view. So let's talk about the Nasopharynx first. The Nasopharynx, posterior portion of the cavity, the nasal cavity to the superior portion of the soft palate. The soft palate. The soft, sounds like I want you to know it, and I do, right? So it goes from there to there, right? The soft palate. You do need to know that. It is only an air passage, right? Only an air passage. That's it, right? So this is just an air passage. During swallowing, the uvula will move up and close it off, right? Which muscle is being used? It sounds like elevator, right? The LVP is being used. What's the nasopharynx lined by? By the nasopharynx, we mean the posterior 2/3, right? It's lined by PSCC. You see how I'm repeating myself here? This is good. Pseudostratified ciliated columnar epithelium cells, right? High on its posterior wall is the pharyngeal tonsil. This is the adenoid. Which traps entering, hopefully if it's a tonsil, it's trapping entering pathogens. Right? It's trapping those pathogens. And also in the nasal pharynx, we have what's known as the Eustachian tubes. I'll just write the letter E in here. You have fun writing that in. The Eustachian tubes open into the lateral walls, and they connect the middle ear to the nasal cavity, and they serve as a pressure release function. So have you ever seen it where people are flying on an airplane, and then they do that whole thing where they close their eyes, and then their mouth, and they back pressure, right? They're trying to get the middle ear to open up and pressurized with the nasopharynx, right? They're trying to relieve that pressure in there. So that's what they do, is their pressure relief function. So I want to talk about something here with kids. With kids that have are more prone, if they have an upper respiratory infection, are more prone to ear infections as well. Or if they have ear infections, they're more prone to upper respiratory infections, because the Eustachian tubes on an adult are, let's just draw it up here. Here, I'll go to purple. The Eustachian tubes on an adult, and we'll just say the ear's over here somewhere. The Eustachian tubes on an adult go down, right? It's a downward momentum. So usually pathogens don't go back up. But in kids, it's almost an even straight shot. And plus not only that, neonates spend most of their time lying down, so that doesn't help things either. And so kids, if they have an upper respiratory infection or an ear infection, can lead one to the other pretty easily, because pathogens can travel back and forth pretty easily on those little guys. And I believe your book also talks about that too. The tonsils and adenoids. Tonsils and adenoids, they can be removed if a kid has obstructive apnea. Sometimes the tonsils and adenoids are too big. They can remove that to help them relieve some of their breathing obstruction. So you can see a lot of different things that happen with the nasal pharynx, but hopefully you remember the function of, or the function of the Eustachian tubes, where it empties, where it's located, which is in the nasal pharynx, what it's lined with, the pseudostratified ciliated columnar, right? And this is only an air passage. You shouldn't put food up your nose. The oral pharynx. The oral pharynx is posterior to the oral cavity. So it's going to start roughly, it's purple, okay, up here, right? That soft palate. So it extends from the soft palate to the base of the tongue, or anteriorly the hyaloid bone. So towards the base of the tongue or the hyaloid bone, right? So up here to up here. So this is the oropharynx, right, from a side view, right? This one has food and water, or food and liquids, I should say, that go through it. So this is lined with stratified squamous, right? So this is going to be stratified squamous, or simple squamous. It sort of changed there. It has tonsils in there on the lateral walls. You have lingual tonsils that are over the base of the tongue. And this is one of the weird places where if you do work with trauma victims, the hyaloid bone, this is one of the first things that they'll check for a strangulation victim if the hyaloid bone is fractured, because with strangulation, that's one of the things that can get fractured pretty quickly there. So that's the oropharynx, from the soft palate to the base of the tongue, stratified squamous. Then the laryngopharynx, or hypopharynx, right? Remember, that's the alternate term is hypopharynx. That's what should go in that box there on bullet point number 1. Hypopharynx, right? So this extends from the base of the tongue to the entrance of the esophagus. So let's go back to purple. So from base of the tongue to the entrance of the esophagus. I'm just going to be back here. So that's your hypopharynx or your laryngopharynx. When you're looking at this, and the esophagus is where it goes into, I would remember that. I'll put E there. Esophagus. So that's where that ends. So remember, you need to know where each of these start and where they end. I will ask you, hey, where does the laryngopharynx start and end, right? In one way or another, you're going to say, hey, it's from the base of the tongue and terminates at the esophagus, or true and false, base of the tongue to the esophagus. Yeah, that's going to be true, right? So you do need to know these. Like I said, that's something I will ask of you. So this one is going to be lined with, and remember, because it goes, it still has food and liquid that can go through there. So if food and liquid go there, it's not going to be pseudostratified. It's going to be stratified squamous, right? Stratified squamous is going to be the big thing here. So if it has food and air that go through it, it's going to be stratified squamous. If it's an air passage only, it's going to be pseudostratified dilated columnar, right? So both your oro and laryngopharynx have stratified squamous in them. The cool thing about the laryngopharynx, it's innervated by the glossopharyngeal nerve, and the 10th cranial. So it's both your 9th and 10th cranial nerves, and the 10th cranial nerve is a motor. It's that vagus motor nerve, and so you can actually see people with brain injuries or strokes that have effect with their oropharynx or their laryngopharynx, I should say, their laryngopharynx from those injuries as well. So it's something to pay attention to. The larynx, also known by some people as the voice box. This is a good picture up here. Here you can actually see, let's move to yellow. Let's see if you can see it here. And then I'm trying to point those lines to the vocal cords. You see those little white lines in there? Those are supposed to be the vocal cords. A lot of stuff is swollen in this person's throat. So that's just a way to look at the voice box or where the vocal cords are. This is the opening into the trachea from the pharynx, right? This is from the laryngopharynx. It's located between the base of the tongue into the laryngopharynx, the upper end of the trachea overall. So the main tasks of this is it's an air passage between the pharynx and the trachea. So this should say air passage. between the pharynx and the trachea. So it routes air, food, liquids, and to where it's supposed to go. So if you're drinking something, should it go into your lungs? No, right? It should go into your stomach. So the larynx has the discretion to put food and liquids into the stomach and air into the lungs. So it protects against what's called aspiration. A-S-P-I-R A-T-I-O-N, aspiration. So it protects against aspiration. So aspiration is a term when food or liquid goes down into someone's trachea and into their lungs. That's not very good because that's not where that's supposed to go, right? And so that can ultimately create a pneumonia and other difficult things. I had a patient once who was at the festival, medieval festival, right? And you guys can all fill in the dots there. A medieval festival that's in Larkspur, and aspirated part of a corn dog, which I don't know why they served that there, but doesn't seem medieval to me. But aspirated part of a corn dog, and came in, and we had to do a procedure to help remove bits of corn dog out of him, which is pretty interesting there. The larynx also is voice production and generates sound. Right, so this is where your vocal cords, right? That's what you're looking at here. Those little white lines up there on that picture, those are the vocal cords that you're looking at there. That's what vibrates when someone's exhaling, so that way they can talk, right? Or sing. The larynx is made up of intricate arrangement of 9 cartilages connected by membranes and ligaments. You have 3 single cartilages and you have 3 paired cartilages. You will need to know which ones are single and which ones are paired cartilages. So the 3 single cartilages are the epiglottis, the cricoid, and the thyroid. The epiglottis, the cricoid, and the thyroid. The 3 paired cartilages are the cuneiform, the corniculate, and the arytenoids. The cuneiform, corniculate, and the arytenoids. So you have 3 singles plus 3 pairs, right? Remember, these are paired, so that's what makes this total 9, right? Because there's 6 of these plus 3 of these equals 9 cartilages. Alright, so this is a picture from your book, and this is sort of highlighting different angles to look at this, and this goes into way more detail than what I can go into here because this is already long enough as it is. But you can see the singled and the paired cartilages. The single paired cartilages are in here. So when we're looking at the epiglottis, that's this first one up here. Let me go to purple. Epiglottis or blue. Let's do blue. Epiglottis is this first one up here, right? You see it from the side view and from the back view and from the front view. The epiglottis is this big one up here that flops and closes the airway. It protects the airway from food or liquids, right? It just closes it off. And when we go to intubate, this is what we're trying to move out of the way, is that epiglottis, right? The next one here that you'll see as a single cartilage is the thyroid cartilage. And then here's a side view of it over here. So the thyroid cartilage is that big shield-like one in the middle. And then it forms together and forms the Adam's apple ultimately. And then finally, your last single cartilage that we'll highlight here is the cricoid cartilage. Right? The cricoid cartilage is that one that's right underneath, and so the area between the thyroid and the cricoid, there's this cricothyroid membrane that I just circled. So that's that cricothyroid membrane. And then if you've ever heard of a cricothyrotomy, so if they have to cric someone, let's say someone was a strangulation victim and we can't get a tube in from their nose or from their mouth, we can put a little tiny tube right through that little membrane there. So it's a tiny tube. It's not like a large tube. It's a very tiny tube because it's not a large space to begin with. And that's a cricothyrotomy, and you can feel this on yourself. So feel for your Adam's apple, right? And then you can feel your cricoid and your thyroid, right? You can feel them. And then that space in between, if you're touching your throat right now, that space in between, you can actually push in on it a little bit. That's that cricothyroid membrane. That's what you're looking at there. So those are your three single cartilages, the epiglottis, thyroid, and cricoid, and that gives you sort of a picture of where they're at. When you're looking at the side view, your cuneiform, your cuniculate, and arytenoid, so your cuneiform up here. You guys see that one? Your cuneiform's up here, the cuneiform, and then your corniculate is the very top of the, you guys sort of see this thing, it looks like a pyramid over here. So the corniculate's the very top part there, right? The very top part of the pyramid. It's like the Luxor, right? The very top part of there. And then finally your arytenoids. Arytenoids are down here. They're the base. And they sort of anchor the vocal cords together there. So that sort of anchors the vocal cords on the back. The cuneiform and the cuniculate help modify speech as well. So these are going to be something that you might need to know, especially if someone has a stroke or people have swallowing difficulties or traumas to the airway. These all come in handy. So the large shield-shaped single cartilages is going to be the thyroid cartilage. So that's what goes in up here, is T for thyroid. The thyroid cartilage is formed by the fusion of two cartilage plates. This happens in utero, right? So the fusion point is called the laryngeal prominence, also known as the Adam's apple. That's what, if you want to put that in there, that's up to you. Also known as your Adam's apple, that's what a lot of people know it as. Right below it, or inferior, same thing, right inferior to the thyroid cartilages is the cricoid cartilage. That's this guy here, right? We got the thyroid and the cricoid cartilage. The cricoid cartilage, that's what should go here, right? The cricoid cartilage is a membrane. The cricothyroid membrane has a membrane for emergent airways. That's what I was talking about on that previous slide there. This is the first what they call C-ring, and we'll get into that in a second. And it lies below the cricoid cartilage. So right below the cricoid cartilage is your first C-ring, and it's incomplete posteriorly. So the only complete tracheal ring is actually your cricoid cartilage. Right. I will repeat that again. The only complete tracheal ring is your cricoid cartilage, right? So right below the cricoid cartilage is your first C-ring, right? So after this, that's where we get below the cricoid cartilage. That's sort of where your vocal cord area would be. And so now we're starting to get to like that look of we're getting closer to the lower airway. So remember, within this area, within this whole area posteriorly, we're looking at the anterior view in this picture. We have three small paired cartilages that sort of help with phonation, with talking. The arytenoid, the cuneiform, and the corniculate cartilages are going to be from the part of the lateral posterior walls of the larynx. So the arytenoids are the ones that anchor the vocal cords, and they hold it there. The corniculates and the cuneiforms help move the vocal cords. So if there's vocal cord dysfunction, and if you don't know what vocal cord dysfunction is, it looks a lot like asthma. People have difficulty breathing, they require high oxygen, their body's working really hard to get a breath, and because the vocal cord's hanging up in the middle of the throat instead of moving out of the way while they're breathing in, it's going to make it hard for them to breathe, right? So those could be damaged or have problems, and that's something for ENT, an ear, nose, throat doctor, to look at, or also known as the otorhinolaryngologist person. Right, the arytenoids, let's talk about those. The arytenoid cartilage is shaped like a pyramid, right, which rests on the posterior portion of the cricoid cartilage, right? So this is a better picture, right? You see how it looks like a pyramid over here? Right, on both of these pictures, you see how those look like a pyramid. The arytenoid is shaped like a pyramid. At the base of the arytenoid is a projection called the vocal process, which is where the vocal cords attach to. And the cuneiform and the cuniculate attach right there at the top to help move the vocal process as people talk. So that's going to be something that helps them speak. So the cuneiform and cuniculate are accessory cartilages, and they, like I said, help articulate speech, but the one that anchors the vocal cords is the arytenoids. And it's cool because it starts with an A, like the arytenoids, and it's shaped like a pyramid, which is like a giant capital letter A, right? The epiglottis, we're moving along here. The epiglottis is the ninth cartilage, right? It's spoon-shaped, it's mostly elastic. It covers almost entirely by taste bud mucosa. Isn't that crazy? So that way you know something's going in the wrong place. During swallowing, the larynx is pulled away, right? And the epiglottis tips over the laryngeal inlet. In other words, this whole thing lies flat to cover this area. So that way all the food and liquids goes back here into the esophagus. So it sort of flaps down and covers it while you're eating and drinking, right? This is like those trash can lids that open and close when you step on the foot pedal. It closes when you're eating or drinking and it opens when you're breathing. I don't know if that's a good visual for you to think of. So next time you go to a trash can where you have to step on the foot pedal and you see the lid open, you're like, hey, it's like an epiglottis, right? There you go. If anything other than air goes into the larynx, this should stimulate a cough-gag reflex, which is the glossopharyngeal reflex. And the motor vagus nerve creates a gag. This is also known as the pharyngeal reflex. Pharyngeal. I ran out of room. But the pharyngeal reflex, that's that cough gag reflex. This is something that you should have as long as you're conscious or semi-conscious. If a patient does not have a cough or a gag reflex, it's very dangerous because it means that there's a chance that they could aspirate and cause major harm to themselves. All right, and so this is just a different way of looking at all these cartilages. I won't spend time on this because we've already gone through this one. So let's go to the next one. This one is a different picture. I like looking at different ones. This one is missing which cartilage? I see the corniculate. I see the arytenoid. I see the thyroid. I see the cricoid. Which cartilage is missing? This is sort of like a quiz, mid-quiz question, right? I see the corniculates, arytenoids, thyroids, cricoids, epiglottis. Who's missing? I will tell you it's one of the small paired cartilages that articulates speech. Yeah, it's missing the cuneiform, right? So this is just like a little quiz question. So when we're looking at this, we're looking at pharynx versus the larynx, right? You see the epiglottis here. Let's go to purple. See the epiglottis here, right? Just like that trash can lid. It's supposed to close down. So it moves down and closes off. The ability for food and liquids to go into the trachea. That's the whole point. So the pharynx and the larynx is the big thing here. That close communication between the two while you're drinking or eating. When we're looking at the vocal cords will vibrate, right? You already know this. The vocal cords vibrate to produce sounds. So I'll just put a V there. Vibrate to produce sounds as air rushes up from the lungs, right? So as you exhale, that's when you'll vibrate your vocal cords and therefore talk, right? Phonate. Superior to the true vocal cords, so right on top of the true vocal cords, is a pair of folds called the vestibular folds. So these vestibular folds also have a synonym. Isn't that good? No, it's not. But the synonym for vestibular folds is the false vocal cords. So you have your true vocal cords,
and then your false vocal cords. The false vocal cords are sort of a protection for the true vocal cords from trauma or injury, anything like that. The superior portion of the larynx is lined by stratified squamous. We talked about that. That's that food or air. So stratified squamous up here, right? We're above the vocal cords. And below the vocal cords, what do we have? Once we pass through here, we have pseudostratified, right? So above, stratified squamous, below, pseudostratified, right? So food and air up here, just air down here, right? Hopefully that helps a little bit there. The medial opening through which air passes is called the remiglottis, or we just call it the glottis, G-L-O-T-T-I-S. That's what it's supposed to say. That's the glottis. Glottis, the same thing. In an adult, so in a big person, A-D-U-L-T. In an adult, the glottis is the narrowest part of the trachea. It's the narrowest part of the larynx, right? That is the hardest part to get a tube to pass through if we're intubating. And an infant, like a little baby, and then I'll have to show you guys, we have little baby intubation mannequins, and we have big people intubation mannequins, right? And I'll have to show you. In an infant or a small child, the cricoid cartilage, so I'll just put CC, the cricoid cartilage is the narrowest point, right? The cricoid cartilage, remember, is below the vocal cords, and so that's going to make it tough, because if it's below the vocal cords, then we could still get a tube past the vocal cords, but we can't get it past that part where we're having the hardest time to get gas to go through. We can't bypass the bad part of the airway, right? We can't get past the part that's sick, right? So it's pretty hard on infants to sort of get past that altogether. The other thing too is when we use an endotracheal tube for a baby, you can Google image baby endotracheal tubes and adult endotracheal tubes. Adult endotracheal tubes have a little balloon on them, and that we inflate to help stop air from coming around the sides of the trachea up and out. With baby ET tubes, with like a 3.0 ET tube, we don't have that balloon on the end of it, and that we don't need it, because as long as we use the right size of tube on that baby, that means that the cricoid cartilage is able to sort of keep gas from going back up and out. So we sort of can use it as an artificial balloon, which is kind of cool, or an anatomic balloon in a way. It's kind of cool. Last point on here, subglottic swelling due to infection or trauma can cause a high-pitched squealing noise during inspiration known as stridor, S-T-R-I-D-O-R. That's what's supposed to be there. Stridor. Right? Good name for a band, right? A high-pitched noise. It's like a crowing noise. Right? It's very, very weird. Stridor usually means something upper airway is going on. Usually foreign body or swollen trachea. Something like that's going on. So let's look at the swallowing motion altogether. So we're looking at swallowing. The tongue moves up. When you swallow, your tongue moves up and forward. So it moves, let's go to a darker color here. So when you're swallowing, your tongue moves up and forward, right? If we're using this picture. So your tongue moves up and forward. While this is happening, your LVP moves, hopefully you remember, up and back, right? That soft palate covers that nasal pharynx, right? This is that part, and it covers it, so it moves it up and back. So your LVP moves that up and back, and as you're swallowing, right? And here you see the uvula covering or blocking the opening of the nasal pharynx. So as you're swallowing in the second picture, right, this is the bolus, this is what you're eating or swallowing here. Hopefully you have your epiglottis that's blocking the trachea from having any food or liquid go into it. And then hopefully as that bolus or that food or liquid that is going down is past that point, then the palatal pharyngeal, which moves down and forward, right, opens up that nasal cavity again, right, and the epiglottis then opens back up again. So that's sort of giving you, during a swallowing motion, what's happening with the uvula and what's happening with your epiglottis, right? It's kind of a cool thing there. The big thing here is in RT, you need to be able to identify anatomical landmarks, especially if we're going to be part of placing emergency airways. So hopefully we'll get to practice this when we get back to campus. Right, so this is that side picture of an endotracheal tube being put in, and you can see how it bypasses the upper airway. It bypasses the upper airway. It bypasses the upper airway. And you notice I repeated that on purpose. All right, so you see how it bypasses it. We got to get it past the epiglottis and the tongue, and those are the two big things when we go to put in an emergency airway for an endotracheal tube, is to get it past the epiglottis and the tongue. And so we have specific ways of moving the tongue and the epiglottis. We have two different blades. We have the Mack and the Miller blade, and both of those are designed to help move the epiglottis out of the way, and this will be where we're starting to get into application of that. So the epiglottis and the vallicula, the space between the base of the tongue and the epiglottis is called the vallicula. So these are very important landmarks. So if I ask about landmarks, this is the slide that you should bring into your brain. This is the vallicula, V-A-L-L-E-C-U-L-A. The vallicula, right? This is an important landmark because if we're using a Mack, if we're using a Mack or a curved, right? If we're using a Mack or a curved intubation blade, then the tip of it will be put into the vallicula, and that will cause that ligament to be shortened up, and the epiglottis will move out of the way. So this is something where I wish I could do hands-on with you and show you our models and stuff like that. Maybe we can do something down the road with that. But that Mack blade goes into that area between the base of the tongue and the epiglottis, and we just shorten that ligament, and that ligament will move the epiglottis up and out of the way so we can insert that ET tube. Another way of doing and getting past the epiglottis is to directly displace it or to move it out of the way. And this is where we can use, so this one up here, the Mack blade was curved. This one down here is a straight blade, so it's called a Miller. Just like the L's in Miller, it's a straight blade, and it directly moves or displaces the epiglottis, so that way we can put the ET tube in the airway. So there is advantages to one over the other. So the big advantage of a Miller blade is we can usually get a better view if someone's airway is very anterior. We're having trouble seeing the vocal cords. If we're having trouble managing the tongue overall, then the Mack blade is a lot better at managing the tongue and getting the tongue out of the way. So it just sort of depends on the situation. Most adults, they'll use the curved Mack blade because it's indirectly as well, so therefore in theory less traumatic according to, I think, the American Association of Anesthesia. And Miller's, usually for neonates, that's almost exclusively what we use for neonates because their airways are very anterior, and that will give us the best view, and usually their tongue isn't the hard part to get out of the way on those little guys. So this is just a picture sort of outlining the structures for you. Here you see the opening of the esophagus. This is the easiest place to put an artificial airway because that's the most potential. The hardest place is obviously going to be into the airway.
because it's anterior, right? Up here at the tongue is superior. If you're looking down someone's airway, the esophagus would be inferior. So the easiest place to think that you are putting a tube, it would be the esophagus, right? You're like, oh, I see the trachea, when in fact you're looking at the esophagus, and you put the tube in the esophagus. People don't breathe well when the tube's in their esophagus, I will tell you that now. So the vocal cords, that's why if you're intubating, you need to see the vocal cords, right? Before you pass the tube, you need to see those. And that's going to be one of the big ones. So this is just showing you the structures, like I said, and that's going to come in pretty handy, especially when we start getting to airways. All right, so let's talk a little bit about application. All right. So when we're going to different applications, croup and or laryngeal tracheal bronchitis, LTB or croup. LTB, croup has a barking cough, and they'll also show a lot of inspiratory stridor of that that inspiratory high-pitched crowing noise, that stridor. Epiglottitis, when we look at epiglottitis, it can be it's supraglottic, and LTB is subglottic. So this is above the glottis. That's epiglottitis, right? It's above, and croup is below, right? Below the vocal cords, above the vocal cords. LTB is below the vocal cords. Epiglottitis is above the vocal cords. So LTB is subglottic. Epiglottitis is supraglottic. So the big thing here with epiglottitis is it's usually caused by a bacterial infection. And you might go over it in microbiology. It's Haemophilus influenza, and it's actually something most kids are inoculated against. However, some kids may not get that inoculation. It's part of the natural ones that most kids get, and if they don't, they're more prone to epiglottitis. It's a bacterial infection that can cause the epiglottis itself to swell. And you guys see how the epiglottis is swollen right there? And because it's so swollen, it's closing off the ability to get air into the trachea. It's blocking that, right? Over here with LTB, or laryngeal tracheal bronchitis, right? This is caused by a virus. So epiglottitis is caused by a bacteria. LTB is caused by a virus. And then it's usually parainfluenza that causes this one, right? It's usually parainfluenza. It's a lot more common in kids. And notice in this one, it's the swelling below the vocal cords down here. You guys see that? So one's a virus, one's a bacteria, one's above the vocal cords, one's below the vocal cords. They both have a lot of work of breathing associated. One's epiglottitis is an airway emergency because they cannot get past that obstruction. They have a hard time breathing, and if they go to intubate them, you might only get one chance to intubate them because their airway is so swollen. If you cause any further trauma to it, like with multiple attempts, then they could close off altogether and get a hypoxic injury, which is not something your body recovers well from usually. So one of the radiological, so how do you know the difference at the bedside? Well, they're fever. If it's a low grade versus a high grade, all right, high grade fever, bacterial, low grade would be viral, so that could be a clue. But if we get an x-ray, that's a lot better to look at. So if we see what's called a steeple sign, you see how it narrows up there and you see the arrows pointing at it, right? So this is the trachea. You see how the trachea comes to a narrow, like the steeple of a church, right? That's called a steeple sign. That means it's below the glottis, and therefore it's more likely to be LTB, right? And so that's a steeple sign. So if I ask you what might you see on an x-ray for LTB or croup, you would say, right, a steeple sign. They would also have stridor. They would need oxygen, right? It's caused by a virus or bacteria? Virus, right? We're looking at epiglottitis. This is where their epiglottis
is swollen and you cannot see the vocal cords. So this is the epiglottis right here. It looks like a giant cashew here, right? The vocal cords are supposed to be there, but you can't see them because this is so swollen. It's actually hiding. It's blocking the throat, right? The throat really hurts. It's blocking. Like, that kid's not going to drink or eat, right? This is an image from a bronchoscope, right? This is where they can go into the airway with the camera, and they took that picture, right? They're not going to eat. They're not going to drink. They're in pain. They're usually going to be dehydrated because of this. And this is a lateral neck x-ray on the first one here, and then this is the bronch one on the right. So on the left is a lateral neck x-ray. You can see the spine, right, the cervical spine back here. So the lateral neck x-ray, you see what's called a thumb sign right here. So it's like someone's sticking their thumb up like they're doing a hitchhiking thing, right? And because this area is opaque and looks like a ghost film, right? But it's so opaque, right? That's that swollen tissue that's blocking the trachea here, right? I'm outlining the trachea there. So it's swollen and it's blocking gas from going into the trachea, so that way that person can breathe. So they both have stridor. Remember, epiglottitis is caused by a virus or bacteria? Bacteria, right? It's the H flu, right? You can't see the vocal cords. The throat really hurts. They're also going to have stridor. It's an emergency for these patients for sure. All right, so let's talk about the larynx really quick. The larynx is closed. It is closed by the epiglottis. Right, that's what closes it off during swallowing. And we already covered this. This is repeating. And like I said before, I will repeat myself on purpose. That means it's important. So the larynx is closed by the epiglottis while you're drinking. So this is just sort of the mechanics. In addition to opening and closing the glottis for speech, the vocal cords can act as a sphincter during conditions like coughing, sneezing, or straining, right? It's that back pressure that goes on. And hopefully you guys remember the stages of a cough. I believe you might have gone over it in A&P. If you don't, the 4 stages of a cough are inhalation, irritation, inhalation. So something irritates your throat, you inhale, then you compress, right? You back pressure, you close your throat, right? You back pressure it so that way you can expel. And then finally the last one is expel, right? So irritation, inhalation, compression, and expel. And so that's what you're looking at here is we have that sphincter action where it back pressures or compresses so that way they can expel. The mechanics here. So coughing, sneezing, straining, childbirth, right? Pushing, straining, right? It's that closure of that vocal cords, or that epiglottis, I should say. That's really going to help back pressure the thoracic cage, which back pressures the abdominal cavity, which can help with pushing and things like that. And this is a picture of the glottis closing. I love these pictures. I don't know if you appreciate them like I do. But here's the animated pictures over here on the left, the glottis open and glottis closed. And the glottis being closed allows for that compression to back pressure or cough or sneeze or to strain or push. You'll even see some lifting athletes using this back pressure to help them lift very heavy objects too. Right, so this is just the anatomy, the flipped anatomy that you'll see up here. Up here would be, here, let's pick a dark color, the tongue, where I drew the T there. And then down here, the arytenoids, they did not label them. The arytenoids would be, they would be on, well, you probably can't see it. You have your corniculates, which are these guys. You have the cuneiform, which are these guys. And then your arytenoids would be behind this or underneath these. These are superior. Remember, the arytenoids are the base of the vocal cords. So imagine these are below, or you can't see, you're superior to the arytenoids.
See the false vocal cords? They're sort of helping to protect the true vocal cords. You can still see the edge of the true vocal cords here. What's the space in between the vocal cords called? The rim of glottis, or just simply the glottis. The vallecula is up here. Remember, it's between the base of the tongue and the epiglottis. And this is where you'd put the tip of the, which blade? The Mac blade or the Miller blade? Which one would you put there? Which one goes into the vallecula? That would be the Mac blade, right? And the Miller blade directly displaces the epiglottis. Right, so this picture is meant for your, and you'll have to do this in your book too, in your workbook too. So this is where we're looking at. A is the tongue, right? B is the base of the tongue. And so if you're looking to fill this out, that's where I'm just letting you know here. C would be the laryngeal, or the lingual tonsils, sorry, lingual tonsils. D would be your median glosso epiglottic. E is your epiglottis, of course. E is for epiglottis. Vallecula would be F. Your vocal cords would be G, and your false vocal cords as well would be H. We're looking at I is the area epiglottic fold, which is already written in there for you. J would be the glottis or the trachea, right? Please don't say trachea. Please say glottis, right? The space in between the vocal cords, just say glottis, right? That's what I'll be asking of you. The cuneiform cartilage would be K, the corniculate would be L, and then finally M would be your esophagus. So make sure you understand your structures as you go through there. They will be very helpful to you as far as landmarks go. All right, let's look at musculature here. Extrinsic musculature and intrinsic musculature. So we'll start with the extrinsic, or outside. Right? These are the outer muscles, or move it outside. You have your infrahyaloid and your suprahyaloid. Now, in the infrahyaloid, it's below the hyaloid, right? Infrahyaloid, below the hyaloid. It pulls the larynx and the thyroid down the neck. So this is going to be your sternothyroids, your sternohyaloids, thyrohyaloids, and your omohyoid. I probably will not test you on this area. This is not something that I would stress to you as much as some of our other information we have covered. Then you have your suprahyaloid, which is above your hyaloid bone. This pulls the hyaloid bone forwards and upwards and backwards. So forwards, up, and back. And this is that motion that you use to swallow. Right, so this is that thing that can be damaged with like stroke victims, all that stuff, their ability to swallow, and they're not going to have that musculature quite developed yet. And so this is your stylohyaloid, mylohyoid, digastric, so on and so forth, right? I'm not going to stress these areas here. This is more here for completeness sake. Intrinsic laryngeal musculature sounds like something I will test you on. Yes. So this is important because it's what moves the vocal cords. This is important because it is what moves the vocal cords. They deal with the arytenoid. I'm just going to draw the letter A there. The arytenoids, cartilage, and vocal cord, I'll just put VC, vocal cord movement as well. So they deal with the arytenoid and the vocal cord movement. Remember, the arytenoids is what anchors the vocal cords, so that's why they're so closely related. Posterior cricoarytenoid and lateral cricoarytenoids transverse, thyroarytenoids, and cricohyaloid. Oh heavens, right? These are all things that move the vocal cords in different directions. So the posterior cricoarytenoid pulls down on the arytenoids, right? It's posterior and it pulls down. And it causes the vocal cords to abduct. That causes them to open. So your posterior cricoarytenoids equals abduction. The vocal cords move apart. They open. They allow air to pass through. So if someone has trauma to their throat and they cannot open their vocal cords, right? Their posterior cricoid might be what's causing the issue with that, right? Now, what about adducting? What about closing the vocal cords? Which muscle does that? Your lateral cricoid is the opposing muscle. So it pulls up on the arytenoids, and that causes the vocal cords to close or adducts, right? So it closes them, right? So you might want to look at and remember what closes it and what adds it, what closes it and what opens it, right? What abducts it and what adducts it. Now we'll make a strenuous suggestion that you look at. Remember which one adducts and which one abducts. Right. So this is the picture here. So the first picture on the left is the posterior cricoid, which do what? Abduct or adduct? They abduct, right? They're posterior. The way that I remembered this from when I was in school, I don't know if this is appropriate. Hopefully none of you are extraterrestrial, because the way I remembered it is if an alien abducts you, it will probe you. So it's posterior, right? That's where I got the probe part. And it's abducting, right? So it's moving apart. So if an alien abducts you, it will probe you. That's how I remembered it was the posterior cricoid muscles. I don't know if that's helpful or not, or appropriate. Adducting means the vocal cords are moving together, and that's lateral. I remember Larry moves into the middle, right? Lateral. But however you want to think about it. Over here, the transverse arytenoids makes the vocal cords tighter, so that way you can do more high-pitched stuff. Down here, the thyroarytenoid muscle, will loosen the vocal cords, so you can do more deep tone, Darth Vader type noises, right? And the cricohyaloid muscles over here, this will even get you even a lower tone of voice overall. All right, so what's the ventilatory function of the larynx? When you're looking at the larynx, it ensures a free flow of air and to move from the lungs. During inhalation, the vocal cords move. Oh heavens. The vocal cords will move apart is what it's supposed to say there. The vocal cords will move apart. This is abducting, and that improves airflow, right? So we want both of them to move apart so we can breathe easier. During exhalation, the vocal cords will move together, and that's adducting, right? Moves together. So when we're looking this, forced exhalation against a closed glottis is something that is a test we can do, or a procedure we can do. It's called a Valsalva maneuver. So this causes a massive adduction where you're back pressuring like a cough or vomiting, urination, defecation, and childbearing is what that last one is. When you're doing that, that's that back pressure of the thoracic abdominal cavity. So coughing, vomiting, urinating, defecating, and childbearing is what you're looking at there. That's a Valsalva's maneuver. That's a forced exhalation against a closed glottis. So deep breath and then close the glottis, right? Back pressure. That's a Valsalva maneuver. Mueller's maneuver, which is the next one down here. A Mueller maneuver is where you're trying to breathe in against a closed glottis. You're like, why would I ever need to know that? Well, at the bedside, we can do this with a test called a NIF, a negative inspiratory force, to sort of see how strong their diaphragm and respiratory muscles. We can also look for collapsed airways in an obstructive sleep apnea patient. We can also look at their
diaphragmatic movement with ultrasound. So we have the patient, we put an ultrasound over their diaphragm, we look for diaphragmatic movement, why they try to take a deep breath in with a closed glottis. That looks at how strong their diaphragm is as well. So this was a disputable question by a student, and so that's why I always I'm like, you went over this. This is something we covered, and I know we covered a lot of information, but that was one of the things we did cover. So you should know the difference between a Valsalva maneuver and a Mueller maneuver as well. Hopefully this concludes all the upper airway. Remember to read the chapter, do the workbook, take breaks during this lecture, then just, of course, replay it at all times during the day at all times, right? Have fun. There will be an MRE over this information. Online access, hopefully you guys have it to your book, and then they might have some online tools for you. We'll see. I don't know about that currently.